Hi and welcome everyone to yet another session, a session that has been kept because it has been asked for. So today's session is going to be a very interesting one, a pretty long one. I'm going to say that it is going to be a long one because, of course, uh, there are going to be several procedures, several rare procedures that we are going to be discussing. Let me just put in a message on all the groups so that before we begin. uh, So just give me a minute. Let me just check if it is airing on YouTube. I'll be playing your live messages over here. It will take me a minute. Let me just put it on the group. I'm just waiting for everyone to join in. Okay. So posted on all the groups. Mm, ops procedures. Yep. So I hope I'm audible. Please let me know in the chat if I'm audible enough. If there is any disturbance, please let me know so that I can make changes accordingly. Please let me know in the chat if I'm audible enough. And we shall begin now. I'm just waiting for you all to mention in the chat if I'm audible. Yeah. So, welcome to this session of Conceptual OBG. Conceptual OBG, as always, bringing to you the lectures that matter. And today, I'm back with yet another such session, a monthly YouTube live session. This time, it is going to be on a topic that has been asked frequently. It has been asked in parts. Individual surgeries have been asked for, individual topics have been asked for. And there are several procedures. Obstetrics is a completely surgical topic as much as it's a medical, but it is significantly a surgical topic. And there are going to be several such things that we are going to be discussing today. We are going to touch down upon a lot of things. Now, there are going to be things that you have already read, but the priority is going to be to mention those things about those topics that you have not read about. So they are going to be talking about, we are going to be talking about all those kind of questions or all those things that you will be asked in your exams, in your practical exams, in your vivas. And these are those kind of things that are going to earn you the brownie points. Of course, if you are watching this session, once you're done with this, you can be rest assured that all the surgeries that I'm going to be talking about, not just surgeries, but even all the procedures like vaginal assisted delivery, assisted, that is instrumental delivery, all those things, you're going to be pretty good at it. You're going to be able to at least answer in your exams, and bare minimum you can pass even if you have not read anything else. So let us begin with today's session. I have already posted what my objectives are going to be. So when I'm going to be talking about, I'm just going to be keeping, I have a reference that is kept ready so that I do not miss out on anything. I've made a reference chart, a flow chart kind of a thing, so that I don't miss out on any procedures. So when I'm going to be talking about this, let me just keep my own thing on. Yeah, yeah. So when I'm going to be talking about OBS procedures, there are going to be several of them. So I need a way in which I can segregate or I can sort those procedures as per the antenatal or the period of gestation in which I'm going to be talking about. So when I say this, The surgical procedures or the obstetric surgical procedures are going to be divided by me as an arbitrary thing into, first of all, antenatal procedures, then intrapartum procedures, and lastly, my postpartum procedures. Well, so when I talk about the antenatal procedures, there are going to be several. So right from my first trimester towards my third and the later trimesters, I'm going to be talking. Intrapartum is going to be everything that correlates with my process of delivery. It will include my operative cesarean delivery. It will include my operative vaginal delivery. It is also, of course, going to include my vaginal delivery and all the complications that arise out of it. And in my postpartum period, if there are any complications like postpartum acute inversion of my uterus or something like postpartum hemorrhage, that is what I'm going to be tackling in this scenario. So, when I talk about the antenatal procedures, I have decided to divide them first of all into abortion related procedures, wherein there is a miscarriage. So, when I say abortion related procedures, it can be what we commonly use, the manual vacuum aspiration. Then I can have my very famous dilation and curettage, and then suction and evacuation, which is more and more now getting obsolete in my opinion, and it should get obsolete. Apart from that, the next is going to be when I talk about surgeries for ectopic pregnancy. So when I talk about ectopic pregnancy, I'm going to have two options. Either it can be what we commonly do, that is salpingectomy, or what we rarely do, that is salpingostomy. Next, I'm going to have procedures for cervical incompetence. In that cervical incompetence, I am going to be having Shirodkar or Shirodkar circlage and its 3 to 4 modifications. I'm going to mention all of them. Apart from that, I'm going to have my most easily done, that is McDonald's, but not the most effective one. Then I'm going to have my transabdominal, or what we also call as the Benson and Durfee circlage. And lastly, it is going to be something that we call as the worms stitch, worms, W-U-R-M, not W-O-R-M. Apart from that, I'm going to be talking about antenatally all the fetal procedures which correlate or which are done for the fetus. It can be my amniocentesis. It can be my CVS, that is my chorionic villus sampling. It can be my fetal reduction. And there is going to be fetoscopic procedures. I'm not going to be talking about fetal surgeries. By the way, on our application, I've spoken in length about all the fetal procedures that we can do, all the fetal surgeries, everything. It's a topic that I've covered in great length and at great extent. I have covered everything. There is someone who has asked, will it be available on YouTube? Yeah, I am reading the live chat, by the way. See, at this point, I cannot assure you if it is going to be available. The reason that I say this is, I mean, uh, it is always better that you all attend it live, and I'm not going to be giving any false assurances that it will be available. We do intend possibly to take down all these videos and just keep them exclusively for our subscribers. Okay, so these are all the fetal procedures. Apart from that, there are few procedures that are done just before labor begins, like ECV, that is external cephalic version, or things that are done intrapartum. But since I'm going to mention ECV over here, I'll also mention that procedure over here, that is IPV, that is internal podalic version. So these are all the antenatal procedures that I am going to be talking about. So if I'm going to be mentioning how many of them are 3 plus 2, 5, 5 plus 4, 9, 9 plus 4, 13, and 15. So 15 antenatal procedures are what I'm going to be talking about today. Next, I shall have intrapartum procedures. So in the intrapartum procedure, I am going to be talking about vaginal delivery. Of course, I'm going to be talking about instrumental vaginal delivery or assisted vaginal delivery as we call it. And lastly, I'm going to be talking about cesarean section and its multiple variations. Under vaginal delivery, I'm also going to be discussing about episiotomy, and obstetric anal sphincter injuries. Basically, your higher grade perineal tears. In instrumental delivery, I'm going to be talking about ventues and four different types of vacuums that we have, and of course, forceps. And I'm going to be showing you 3 to 4 different types of forceps. When I talk about cesarean section, I'm going to be talking about the usual lower segment cesarean section that you do. I'm going to be talking about the Misgaul Ladakh technique. I'm going to be then talking about an rare form of cesarean section, that is extraperitoneal cesarean section. It is rarely done now. I believe it is a lot to do more with the advent of antibiotics and just lack of expertise. But yeah, extraperitoneal cesarean section. I'm also going to be talking a bit about. Do remind me if I'm to forget, by the way, about a special category of cesarean sections which I call as the deeply engaged head cesareans. Deeply engaged heads. So over here, I have intrapartum 2 plus 2, 4, 4 plus 4 plus 4, 8. So 8 procedures. So until now, I have 23 procedures that I'm going to discuss. And now, finally, the postpartum period, wherein I'm going to be talking about the PPH surgeries. And also, I'm going to be talking about the tubal ligation. Tubal ligation can also be done during cesarean section, so it can also be considered an intrapartum, but usually we do it as an interval TL, interval or puerperal tubal ligation. So I have decided to consider it under postpartum. So different types of tubal ligation. And lastly, it is going to be for hysterectomy and the types of cesarean or peripartum hysterectomy. So over here as well, I have 3. So almost 30 procedures, because in PPH also I have multiple things that I'm going to be talking about. So over 30 procedures of what I'm going to discuss in the next session that is going to go on for 2.5 hours. So I hope the live is going well. It is going, yeah, it is going well. Okay. Class duration. So the class duration, please don't ask me because it's a live session and I really don't know how long is the class going to go on for. So please, I have absolutely no idea how long will this class go on for. So, beginning with the first segment of today, and that is going to be my antenatal surgeries or procedures. So, the first procedure that I'm going to be talking about is going to be abortion related procedures. Now, of course, I'm not going to go into the exact details. I'm going to tell you all the points that you may not know or the points that are going to give you those brownie points in your exams. So when I talk about abortion related procedures, the safest procedure that we have now is going to be my manual vacuum aspiration. This in itself has come from something that we used to do earlier, that was suction and evacuation, but was a little more dangerous. And then we have DNC, which is still being done at many centers. So to talk about MVA first, this MVA is done by something that we call as the, I'll show you the image now. Now this, what you can see over here is the Harvey Karman syringe and cannula. Now, by the way, of course, you would know. I'll have to just change the ink color over here. So this one that you can see is, of course, the syringe. And what you can see over here, all of these are the cannulas. What you can see over here is that you can see that this is the thinnest and this is the biggest size. So over here, the smallest size is going to be 4 and the largest size is going to go as much as 12. Now you would ask me, why is this 4 to 12 a thing that I need to remember? First of all, there is this color coding. You do not need to remember the color coding because if you see this very closely, you would see that on every cannula, there is a mention of the millimeters of diameter basically. All of them are mentioned over here. So you do not really need to remember the color coding. But you would ask me as to why, sir, is this 4 to 12 a thing? Before coming to that, let me just tell you a few properties of this device. First of all, very important that I would want you to see is this. You see this? This is called as a valve. These two things that you can see, these are called as the valves. Now you see that there are two valves, which is why this MVA, this is the latest modification, the one that was made by Harvey Karman, only had a single valve. But now we have a double walled, double walled MVA syringe or Karman syringe and cannula. So first of all, it is double walled, which gives me a lot more pressure, and also it gives me a much more effective procedure. I do not need to reload it again and again. So the latest modification, first of all, is that it is a double-walled cannula, syringe that we use nowadays. It is made from polypropylene. It is made from polypropylene. Now, this is made from polypropylene, and it is of course color coded. It has a capacity. This syringe has a capacity of 60 ml. And once you pull this plunger, when it is pulled downwards by your hand, it creates a pressure of 660 millimeter of mercury. This is the pressure or the vacuum that is created, and this is created within 5 seconds. In a few seconds, 2 to 3 seconds, can that in fact this suction is going to be created. You would know why am I talking about all this at a later point when I talk about suction evacuation. But this is a very important aspect that you need to know, that this is the vacuum that is created by it. Now coming to the question as to why do I have sizes from 4 to 12? Now it all depends, the syringe or the cannula that you're going to use depends on what is your gestational age. So if my gestational age is 5, then I'll be using a 5 size ka cannula. But then you would ask me, why not anything less than 4? The answer is that you will get to know that you're pregnant only when you have missed your period, your menses. And when you miss your menses is going to be at the end of your 4th week. So it is impossible for you to know before your 4th week that you're pregnant. Your UPT is also probably not going to come out to be positive, which is why the sizes have been given from 4 weeks onwards till 12 weeks. After 12 weeks, there are proper fetal parts and bones that are formed, which will not be able to be aspirated out by this manual vacuum aspiration syringe. Those bones are going to occlude. They are in fact going to get stuck inside, which is why I'm not going to use an MVA syringe beyond 12 weeks. Beyond 12 weeks, all I'm going to do is give that patient mifepristone, then give it misoprostol, and I'm going to let the patient deliver vaginally, just like a mini labor process. So until 12 weeks, it is safe to use it. Uske baad mein the bones are going to obstruct and they are going to cause mess completely, and hence it is only given in sizes between 4 to 12. This cannula can be used as many as 60 to 75 times. It can be washed in Sidex and then cleaned in normal saline, and it can be used 60 to 70 times. And this cannulas can be used, per cannula can be used up to 10 to 12 times. So this is another modification. The earlier ones were only able to be used for 50 to 60 times, and these cannulas were, the syringe was used only 50 to 60 times, whereas the cannulas were only able to be used for 5 to 7 times. So the durability and the material, the quality of material also has been improved, and hence it can be reused as many times. Now imagine that while doing this procedure, you can see, by the way, that the tip of this is completely round and blunt. So it is very unlikely that you're going to go inside the uterus and you're going to rupture the uterus or perforate the uterus with this blunt end. But फिर भी मान लो कि तुमने rupture कर दिया, बहुत ही aggressively कर दिया, या फिर it was a patient with previous cesarean section and you ended up rupturing it. Now the good part about this device, this Harvey Karman cannula, is that immediately after perforation, the vacuum drops down to 10 millimeters of mercury. What this does is, this is so low pressure that it will not stuck inside itself any of the visceral organs. It will not suck in itself the bladder or the bowel or even the peritoneum or omentum. That's a good thing. And a sudden loss of vacuum, I'm going to easily feel it, is going to give me an indication that there is something that has gone wrong. Probably I've perforated. Of course, there is going to be bleeding through the vagina and everything. But the main thing is, your visceral organ damage is significantly prevented. Why do you need to know this? Now, you need to know this because this is the reason why this MVA came into existence in comparison to this apparatus that you can see, that is called as a suction catheter and the suction machine that you can see over here, a huge machine, because these both were used for the process called as suction and evacuation, wherein it used to work first of all on electricity, Whereas your MVA is going to be used all on your manual pressure. You do not need electricity. So even in rural centers and primary healthcare centers where there is no electricity or where there is no 24 hours of electricity in that small setup, you can still use an MVA, but you cannot use a suction evacuation. Secondly, this was made up of metal. This metal had only one size. You can see this metal had only one size. So you had to separately use Hega's dilators to dilate the cervix. So basically, first you have to dilate and then insert the suction catheter. Whereas in this scenario, you can directly just start inserting these cannula from the smallest size till the size of gestation. So if it's an 8 weeks gestation, like here, 8 weeks ka hai, so you start with 4, 5, 6, 7, and then you come at 8 and then you start the procedure. Whereas in this, you have to first do dilatation and then insert the suction catheter. Apart from that, this was metallic, and because this was electrical, there was no way this would stop even after perforation. So it would end up sucking in itself all the organs. I have seen an injury because of this. The bowel was pulled completely inside. It was shredded. It was literally shredded, and resection and anastomosis had to be done abdominally for that patient. So of course, it will also pull your peritoneum and very mainly your omentum. So it can be a disastrous thing if you're going to be using it, and hence this is becoming gradually more and more obsolete. You would ask me then, why does it even still exist? Why is it not completely extinct? The reason is that it will have a larger quantity. As I mentioned, my Harman's cannula or Harman's syringe has only a capacity of 60 ml, whereas this, as you can see, will have a capacity of liters. 2 to 3 liters, and I can keep changing these containers. So that was one advantage. But anyway, I do not need itna zyada quantity unless it's a patient with something like a molar pregnancy. Even in that case, I can just use an MVA syringe multiple times rather than using this dangerous suction evacuation catheter. This is the main difference with suction catheter or suction and evacuation and manual vacuum aspiration. Between these two, there is something called as dilatation and curettage, wherein I'll be using a uterine curette, and before that, I'll be using something called as an ovum forceps. Ovum forceps is going to be just a normal forceps without any ratchet. It is not going to have any ratchet. It will not get locked. And I'll be pulling out all the products of conception, which is why it is called as ovum forceps, because everything that is derived from the ovum is going to be your product of conception. So that is why it is pulled out. And then you use that curette to bluntly curate out all the contents. Remember, there is a very common saying that do curettage till a grating sensation is obtained. Now, I completely detest this because I personally believe that if you're going to curate till your grating sensation is obtained, in that scenario, you're going to erode your basal endometrium. So if you're going to erode your basal endometrium, that is going to lead to Asherman syndrome, and you will never get your endometrium back in that location. So never ever do it till grating sensation is obtained. Do it until you see bubbles or until anything stops coming out. Do not keep eroding your endometrium till the grating sensation of obtained. That's a absolutely wrong practice, and that will lead to Asherman syndrome and loss of future fertility. So these are the major procedures that we do for abortions. Have you all understood these procedures? Quickly tell me in the chat so that I can proceed to the next topic. Quickly tell me, have you all understood this, or is there any doubt with regards to this topic? Did everyone understand? Okay. So now I mentioned multiple times about something called as dilatation. And when I talk about dilatation, I need to know how do I dilate the cervix. Of course, my Hega's dilators or my cannulas are going to be useful. But for me to be able to insert those instruments, I need to prime the cervix. I have to prime the cervix, which means I have to soften the cervix so that at least these dilators can go in. Because if I don't do that, I'll end up injuring the cervix and instead creating a false tract through the cervix that will end up injuring the cervix and my uterus eventually. So to do that, I have two drugs called as mifepristone and misoprostol. In that, the most important drug is your misoprostol, which is a prostaglandin E1 analog. So whenever I'm going to be using a prostaglandin E1 analog, that is a misoprostol, that is going to help me prime the cervix. Now, how much of a dose to give for which patient is a very common topic of dilemma. So I would recommend that the next picture that I'm going to show you is a picture that you just print and stick in your labor room, because that is a very useful chart. This is the FIGO 2023 guideline that you can see. This is the latest guideline of the indication and what dose that you are supposed to use. A couple of interesting points over here are that, first of all, they have mentioned that your buccal, sublingual, and pervaginal are having similar activity. A lot of people believe that if I'm going to give it orally or if I'm going to give it sublingually, then it is going to have an excessive activity. No. This chart definitely guarantees you that the pervaginal action and the buccal action is fairly similar, so you can give it through both the routes. And everything is given over here. Just take a screenshot or just print this. You can just get it on internet, called as FIGO 2023 mesoprostol chart, and you can just stick it in your labor room. This will help you significantly in deciding at what gestation do you have to use what dose of mesoprostol. Very, very important. So now coming to the next topic for today. Next is going to be a very simple topic, and that is my surgery for ectopic pregnancy. Now, I have two options over here, surgery for ectopic. Of course, I'm not going to be talking about medical management and conservative management. That's a topic for different day. Today, we are talking only about procedures. So I can either do salpingectomy, which is my most preferred thing, or I can do salpingostomy. Now, what does this mean? Ectomy is resection, whereas ostomy is whole creation. So remember, whenever I have any ectopic pregnancy that I'm going to operate on, be it ruptured or unruptured, one point is that even if it is unruptured, the fact that your ectopic pregnancy has occurred there, it indicates that even if you are to remove it by milking is kya? If this is your fallopian tube, then few people just milk out the ectopic pregnancy from that location. They just pull out the ectopic pregnancy from the femoral end. Now, when you do this, remember that ectopic pregnancy is going to leave behind a few trophoblastic remnants, and those trophoblastic remnants, when they are going to lies down, they are going to cause fibrosis. So you render the patient with a risk of yet another ectopic pregnancy few months down the line when she tries to conceive again. Unfortunately, most of the patients that reach out to us are patients who already have a ruptured ectopic wherein the tube has already ruptured and there is no way that I can do any conservative procedure. In that scenario, what I do is I just clamp the entire tube, I separate it from the mesosalpinx, and then I ligate it after resection. But in a patient in whom, assume Karlo, you have already had a history of ectopic pregnancy before and she has already had salpingectomy done for one side tube. Now she comes back to you again, and the only other tube that was remaining, now she has an ectopic pregnancy in that tube as well. She tells you that, sir, I come from a very lower socioeconomic class and I cannot afford IVF if I lose both my tubes, because obviously if both your tubes are lost, your ovum and sperm are not going to meet. So you will require IVF. She tells you that I cannot afford IVF and the only option that I have today is that you try to spare my tube, because I've already lost one tube earlier due to ectopic pregnancy. Now, if this my second tube is gone, I can never conceive. So in that scenario, I tell her I will do a procedure called as a salpingostomy, but that salpingostomy can only be done if your ectopic is still not ruptured, or if it has ruptured but the tube has not become necrotic yet. In that scenario, what I do is I'll show you with the help of a few images. So over here, you can see that this first thing that you can see is a salpingectomy, wherein I have just held this tube, and this is the ruptured part that I can see over here. There are multiple ruptures. I have taken a scissor, I've resected it, I've removed this, and I will just suture this part completely. So this is called as salpingectomy, wherein I have removed the tube completely away. The other way what I can do is called as salpingostomy, wherein I have made a linear incision, I have pulled out the products of conception. These are the products of conception that I'm pulling out, and then I'm leaving it behind. I'm either leaving the incision to heal without being sutured, or I can suture it. Remember, every time you suture, you place a foreign body, and foreign body will lead to foreign body reaction and foreign body granuloma, and that is eventually going to lead to fibrosis. So what we prefer to do is we just leave it alone and let it heal on its own. Obviously, that can only be done if there is no significant bleeding and hemostasis is achieved even without suturing. This is called as salpingostomy, wherein I've created a hole and I've extracted out the products of conception. Remember though, When this heals, there is still going to be some fibrosis, and this fibrosis is going to lead to yet another risk of ectopic pregnancy. So I have to explain it to her that you will still have a risk of, even in fact, a higher risk of getting ectopic pregnancy subsequently. But this is what we call as salpingostomy. So these are the two procedures that we can do. We can do them abdominally, I mean, exploration say by opening up the entire abdomen called as laparotomy, or you can do it laparoscopically, which is in fact the preferred way of doing any surgery for ectopic pregnancy. So this are the two very simple surgeries and concepts whether to choose between salpingectomy or salpingostomy. And of course, salpingectomy is going to be my gold standard because remember, if I leave behind the salpingostomy thing with that incision open, and if she bleeds later on, she can have hemoperitoneum, and hence it's a risk. Plus, of course, there is a risk of yet another ectopic pregnancy later on. Hence, it's a risky thing, but I only do it when there are exceptional circumstances and the patient doesn't want to lose her remaining tube. This is about salpingectomy and salpingostomy. If anyone has doubts, any doubts, let me know. I'll be now talking, or I'll be now going to the next topic, that is surgeries for cervical incompetency or cervical insufficiency. Does anyone have any doubt? Quickly tell me. Any any doubt? Any doubt? Anybody? Quickly tell me. If not, then I'll start with surgeries for cervical insufficiency. Earlier, it used to be called as incompetency, but now, given that incompetency gives it a negative connotation, the female feels that she is incompetent to have a baby. Hence, now we use the word cervical insufficiency, or in other words, a short cervix. Does anyone have any doubts? Let me know. Are you all liking the session? If there is any doubt, please let me know. I'm looking for feedback in the comments. Okay. So when I talk about surgeries or procedures for cervical insufficiency, first of all, I need to know what are the types of cervical cerclage. The first type of cervical cerclage is going to be history indicated cervical cerclage, which is done between 11 to 14 weeks. Now, history indicated is wherein there are two or more than two abortions that have occurred, spontaneous expulsions, abortions that have occurred in the second trimester, and that history is good enough for me, or there is a history of one or more than that preterm labors, painless preterm labors, which is indicative of a short cervix. So that is history indicated. The next one is ultrasound or USG indicated cerclage, which is done between 14 to 24 weeks and 14 or rather 16 to 24 weeks. This is done when there is a history of preterm labor, but only one history of second trimester abortion. But now in current pregnancy, I have got to see that her cervical length is less than 2.5 centimeters. Does anyone have any doubts until now? No doubts, sir. Oh, Dr. Nupur Sethi. Okay. Yeah, Dr. Nupur Sethi is my KM junior, a brilliant student. Yeah. So USG. This is indicated when there is not history of more than two, but only one previous preterm birth, and alongside that, or there is a history of one abortion, and alongside that, in current pregnancy, I've gotten a cervical length of less than 2.5 centimeters. Now, there's a doubt that arises over here. If it's a priming gravida, or if there's a patient who does not have any history, but in this pregnancy, just on routine screening of the cervical length, we got to see that there is a short cervix. Now, this is a point of dilemma in private practice, and in fact something that even I would personally do, although it is not backed by evidence, is if it is less than 2.5 centimeter, even without any history of preterm birth or second trimester painless abortions, I would still go ahead and do a cervical cerclage. But the guidelines contradict this, and they say that only when there is history of at least one preterm birth or second trimester abortion to go alongside a short cervix is when you do a cerclage. In private practice and even in my practice, I wouldn't really wait for that patient to have a preterm birth or a second trimester abortion. So even in a primary gravida or a patient without history, I would do a cerclage. The last one is an emergency cerclage. This emergency cerclage is done between 24 to 28 weeks. This is called as a worm's stitch. So this worm stitch is basically done as an emergency procedure wherein the cervix has started dilating, and I just need to pull the cervix, the external os together for a few weeks until it reaches the point of viability. So why do I say the point of viability? It is that after 28 weeks, the fetus is given the NICUs that we have. In fact, in India now, even babies who are just above 24 weeks are surviving. Babies of 450, 500 grams, they do survive. But the chances increase significantly if it is going to reach 28 weeks. And hence, after 28 weeks, you will just let the baby deliver. But if it is before 28 weeks, you would try to suture it. There's something called as worm stitch. I'll show you how it is done. And I will try to pull the pregnancy as much as possible. Why not after 28 weeks? Because after 28 weeks, if I'm trying to do it, it will lead to rupture of membranes, or it will lead to chorioamnionitis, or it will eventually or possibly even lead to cervical tears because the weight of the fetus has increased. So worm stitch or emergency circlage only done before 28 weeks. Do not do any form of circlage after 28 weeks. When do I remove all these circlages, especially the history and USG indicated? You remove it at between 36 to 37 weeks, so that when the patient goes into labor, after of course 36 weeks, if she's going in labor, I do not have much of a problem. Now, what are the various types of circlages that I know of? The first one, and the godfather and the best, is Shirodkar. So Shirodkar circlage, he was the first person. It was done by Dr. V.N. Shirodkar. It was done in the year 1955. It was so good that people from Europe, there were several people from Europe who used to come to Mumbai to get operated from him. In fact, there was, I forgot the name, there were a couple of Italian actresses who had histories of multiple second trimester abortions who had come to India to get operated and to get that stitch done from him. He used to use something called as a Shirodkar's cervical encerclage needle. It used to be a needle of this diameter around diameter of around 2 to 3 centimeters diameter. He used to use those needles. There was two needles for both the sides of the cervix. He originally used the fascia lata of the same person or of the same woman. The fascia lata that you find on the lateral aspect of your or tibial tract, jo bolte hain, on the lateral part of your thighs is what you find it. So fascia lata was used, but extraction of fascia lata required another incision on the limbs, which is why it was abandoned. And now what we use is either a Mercilin tape or you use ethylon, that is a nylon suture, ethylon number 1 or number 2. So Mercilin tape or ethylon is what is used now. The procedure that he did was, whenever you're looking at the cervix, he would take an incision anteriorly at the cervico-vaginal junction. And then he would also take a posterior nick at 6 o'clock. Then he would send, if this was my cervix that I'm seeing in the lithotomy position, then the first incision has been taken over here. The second has been taken over here. So he would send one side of the tape. Imagine this blue thing to be the tape. He would send this one side of the tape like this, and then it would come out from here. And then he would send the second end of the tape from this, and it would come out from here. Over here, he used to tie a knot posteriorly. There are several modifications that have been spoken about for this procedure, including a few that said that, in fact, there are a few people who say that Shirodkar first took an anterior knot, but that anterior knot was leading to irritation of the anterior vaginal wall, and it used to erode into the bladder, leading to increased chances of fistula. This is what they say, but there are very few reports which confirm this. So for simplicity's sake, we will just assume that Shirodkar or modified Shirodkar includes a knot that is being taken posteriorly. This knot is tied posteriorly. Now, there were a few variations that were done. The first one was the Shirodkar barter circlage. So the first variation or the first modification was the Shirodkar barter circlage. In this, there was nothing different. It was just that they used a Dacron material or Dacron suture, and the knot was tied anteriorly. This was the first modification. The second modification was the Strom's modification, wherein he used, instead of human fascia lata, and to avoid an incision on the human, he used ox ka fascia lata. And again, he said that I'll put up a anterior knot. The next modification was the man's modification. And in this man's modification, he decided to tie it instead of the cervix at the level of isthmus, that is the point of junction between the uterus and the cervix that is very high up. And of course, this had to be done preconceptionally because you cannot do it when the patient is pregnant. Now, the first thing that I would want you to know is why is this the best form of circlage? And why is McDonald that is easier to do but not the most effective? Before I go to the surgical technique, this is also called as the 3-6-9-12 technique. The technique that is used is the 3-6-9-12 technique, wherein if I'm going to see this cervix, then the first knot is put over here, then it is brought out here, then it is put inside at 3 o'clock, again at 6 o'clock, and this way it will be tied anteriorly over here. So this is how it was put. Now to put into perspective, why is this a difficult thing to do? I will show you an image. Now in this image, you can see that your Shirodka circlage is put at a level that is near your internal os. So over here you have your internal os, and over here you have your external os. So you can see that internal os is very closely put near the internal os, whereas the McDonald circlage is put very close to the external os. Now it is very obvious that higher the suture, the more the integrity. Also, whenever we used to do this procedure in the Shirodka circlage, once the incision was given, there is something called as the endopelvic connective tissue that I've spoken of in the topic of pelvic organ prolapse. So whenever I talk about that topic, I always explain that concept of endopelvic fascia, which is something that holds the all the organs together, and it does not let those organs slip or move around in their area. Now the part of that endopelvic fascia between which is between the bladder and the cervix is also called as the pubocervical fascia. So whenever we take an anterior incision inside that Shirodka circlage procedure, we try to push that pubocervical fascia upwards so that the bladder is also dissected and it is sent to a higher position. Once that is done is when I insert the needle. Now, this is something that requires a higher level of expertise to avoid injury to the bladder, because you should be able to recognize what's the pubocervical fascia and what is the point wherein you are coming very close to the bladder mucosa. So it involves pushing the bladder completely upwards with the pubocervical fascia and then placing it at the level of internal os. But external circlage, or the circlage that is done near the external os, that is McDonald circlage, does not require you to do all this. You don't even have to take an incision. All you have to do is prick the needle and put up the entire circlage in the way I mentioned, from 12 to 3 to 6 to 9 back to 12, and then tie a knot. You do not need to do anything differently. You can also do one thing. You can put it from 12, come to 3, then come to 6, and then from the other side from 12 to 9, and then 9 to 6, and tie it posteriorly. In both these ways, you can do the McDonald circlage. But of course, given that McDonald circlage is not mobilizing the bladder, it is more towards the external part of it, it has a higher chance of failure, and hence the success rates of McDonald circlage, though it is easier, are lesser than Shirodka circlage. The Mann's modification is something that you would do at this level, upwards, even further higher up. But now, as you think of it, the higher the circlage, the better the efficacy. So people started thinking, is it necessary that we do only vaginal circlage procedures? That is when my trans-abdominal circlage came into the fore, what was also called as the Benson and Durfee procedure, or Benson and Durfee circlage. What they did was they opened the abdomen, they dissected all the bladder, the pubocervical fascia, and everything around the area of the isthmus. Then at that area, they skeletonized the uterine artery so that the uterine arteries are excluded from this circlage. They separated it out, and medial to them on both the sides, they passed a Marcelin tape. They came posteriorly and tied a knot. The knot was not tied anteriorly, it was tied posteriorly. You would ask me, why is that the case? Because if you have to give a trial of labor, then you can just do posterior colpotomy. Basically, from the vagina, when the patient goes in labor, you can open the posterior vagina, you can go directly into your pouch of Douglas and cut the tape. But because this is a very dangerous thing to do that can injure your bowel and is also very painful, a lot of people don't prefer to do all this. They directly go ahead with a cesarean section. Needless to say, given that I am mobilizing the entire uterus, a trans-abdominal circlage cannot be done in pregnancy. It can only be done prior to pregnancy, that is preconceptionally. And hence, it's a classical thing that is done only for patients with history indicated circlage. Done preconceptionally, it can be done laparoscopically, can be done abdominally. We use a Marcelin tape. How do we do it? I've again mentioned, I will create two holes in the broad ligament. I will skeletonize. Basically, I will try to separate the uterine arteries. I would not ligate or cut them off. I'll just separate them, and then medial to them, I will pass my cerclage and tie it posteriorly. This was called as the Benson and Durfee procedure or transabdominal cerclage. Does anyone have any doubt about cervical cerclage? Any doubts whatsoever in cervical cerclage and the modifications? Okay, I am assuming that we do not have any doubts. So I'll be moving on towards the next topic, that is going to be the fetal procedures now. Now, whenever I'm talking about the fetal procedures, there are several. So the first thing that I'm going to talk about are going to be amniocentesis, CVS, and chordocentesis. So first of all, when I talk about amniocentesis, centesis is aspiration. Amnio is aspiration of my amniotic fluid. It can be done for a diagnostic purpose or it can be done for a therapeutic purpose. What are the diagnostic needs for me to do it? The first can be for genetic testing. That genetic testing can be something merely like a chromosomal microarray or a karyotype or FISH, so genetic tests or whole genome sequencing, or it can be done to look for infections, intrauterine infections, that is TORCH. So TORCH PCR करने के लिए to know whether the fetus is affected with any of these TORCH infections. Apart from that, it can also be done. It was earlier done for the Lilly's chart for RH isoimmunization. It is no longer done now. So we used to pass light of ultraviolet light of 450 nanometers, and we would check the photometric values of that, and it is to tell me how bad is the isoimmunization. But now with the advent of Dopplers in ultrasound, we only do MCA PSV monitoring. We do not need to do amniocentesis for looking at isoimmunization. But it used to be done for Lilly's charts. The therapeutic purpose mainly is for amnio reduction. Amnio reduction is removing a significant amount of amniotic fluid outside in a patient with polyhydramnios, because that excessive polyhydramnios, that excessive fluid was causing distress to the mother. So every time she used to lie down, it used to cause her difficulty in breathing. It used to completely push her diaphragm upwards. It used to reduce her tidal volume. So because of that respiratory embarrassment, as we call it, for the mother, is why we do amnio reduction. And of course, we have to do it very gradually. We have to remove small amounts, because if you remove large amount, then it can lead to sudden decompression of the uterus that will lead to abruptio placentae. So what is the procedure? The first golden rule that you have to know is this procedure is to be done only after the fusion of amnion and chorion has taken place. So once the amnion and chorion, the two fetal membranes, have fused, is when you can do this procedure, which happens around 16 to 17 weeks. So this procedure cannot be done before that. If you try to do it before 16 weeks or before the fusion, then that can lead to, first is miscarriage, that is inevitable abortion. You'll end up rupturing the amniotic membrane, or you can lead to amniotic band sequence. Amniotic band sequence is going to lead to fetal limb reduction defects. So, or something like clubfoot. So I do not want that, which is why I will only do it once the two membranes have fused completely, and the fusion occurs at around 16 to 17 weeks. So it is very safe to do it after 17 weeks of gestation. To do it, I have to use a 20 to 22 gauge spinal needle. This is a very thin spinal needle, and we use much thicker needles when we do CVS, wherein we are actually taking a specimen or a sample from the placenta. This is used to aspirate it under ultrasound guidance. Now, how much of fluid do I aspirate? To know that, first of all, I'll show you how it is done. You see that this is an ultrasound probe. That ultrasound probe is showing me the entire fetus and the uterus. You see that these two membranes are fused. Before that fusion, you can see in this CVS procedure, you can see this is the amniotic membrane and this is the chorion. They have not yet fused, but over here, both these membranes have fused with each other. This is the difference between CVS and amniocentesis, that both the membranes are fused. Now I have inserted this needle and I'm aspirating it with a normal syringe. Now for every particular test, the total amount of fluid that will be required is going to be different. So for usual CMA and karyotype and fish, the amount is between 10 to 20 ml. Also for allo immunization, it is 20. For torch test, 1 to 2 ml is required for each. So toxoplasma के लिए 2 ml, for cytomegalovirus 2 ml, rubella 2 ml. So ऐसे कर करके 10-20 ml, how much ever test you want to do, it is going to be taken out. Apart from that, for checking for alpha fetoprotein, which is to be done earlier, for looking at neural tube defects, open neural tube defects, only 2 ml is required. And for lung maturity test, that you check for sphingomyelin and phospholipids inside the fluid. It used to be done earlier. It is no longer done. You will be taking 10 ml. So these are the various values that will be required. This is taken from the 26th edition of Williams. So these are the total volumes of fluid that you will be extracting during amniocentesis. Coming to the next procedure, that is chorionic villus sampling. So the name suggests it is chorionic villus sampling. So it is not a true fetal test. Why do I say so? Before coming to that, this test is done between 11 to 13 weeks. Why is it not done before 13 weeks? Because this has shown to cause oromandibular defects. It has shown to cause increased number of abortions. But more than that, remember that most of the aneuploidic pregnancies are going to abort till 10 weeks of gestation. So before 10 weeks of gestation, the pregnancy may itself abort if there is any defect in it. So I would want to wait till at least 10 weeks, so that if it is going to progress beyond 10 weeks, then I can be assured that probably there may not be some gross, very bad aneuploidy that is present, because the body would have expelled it by now. Hence, we wait till 11 weeks. Plus, there are risk of doing early CVS can lead to oromandibular limb defects and a lot of things that are very similar to, but much more severe than amniotic band sequence. Now, this is done between 11 to 13 weeks of gestation, and it can be done trans-abdominally or trans-vaginally. Of course, trans-abdominal route is the preferred route. In this, I'm literally taking a sample of the placenta that is still forming. Remember that placenta is almost completely formed by 12-13 weeks of gestation. So this is the period when I'm doing the test, and I can do the test. Remember, if this is my uterus, if this is my anterior, the patient is lying down, only if my placenta is anterior will I be able to do a trans-abdominal aspiration of this CVS. If the placenta is posterior, because the patient is lying this way, the patient is lying supine, then I will have to do a trans-vaginal aspiration of the sample, which is technically very difficult, and hence people don't prefer. Instead, people just prefer to wait till second trimester and eventually do amniocentesis if it is posterior. So that is one technical nitty-gritty that you need to know about. For this, we use a 18 to 20 gauge spinal needle. Now, this is a thicker spinal needle because you are literally taking chorion. Chorion, that is a part from the your chorionic villi that you know of. These chorionic villi that you know of, जो होते हैं placenta के अंदर, the tertiary villi, they are taken. And of course, given that it's a solid component and not just a fluid like amniotic fluid, you will be requiring a thicker needle. Plus, you have to remember that in this procedure, you are coming in contact with blood, and the blood can clot and can damage the sample, which is why we also heparinize the syringe in which we are going to be collecting this. After this has been collected, remember it is called as sampling. So I'll be collecting it inside a medium. So this syringe that you can see over here is going to contain a culture medium. The culture medium can be various things like RPMI or HBSS or HAM F50. These are few culture medium in which I'm going to collect this sample. As you can see that I'm going to take the needle from this specimen, from this chorionic villi. Now the problem is that there is a high chance that I find placental mosaicism. What is placental mosaicism? Placental mosaicism means that there are few disorders that are going to be completely but exclusively present only inside the placenta. They have not manifested in the fetus. And I can falsely assume that if there is some disorder of this, there is some aneuploidy that shows up in the placenta, it is there in the fetus as well. Which is why this is called as placental mosaicism. Mosaicism matlab something different is there. The genotype of the placenta is different and the genotype of the fetus is different. It is very common, and hence this is not a true fetal test. Hence, the true fetal test is only one, and that happens to be my amniocentesis, wherein I'm taking the same fluid that is excreted by the fetus, either through urine or its skin or through its oral excretions from the lung fields. Hence, a true test of fetus is always going to be amniocentesis and not CVS. This was about CVS, and of course, as they have shown over here, the placenta, if it is anterior, we can do a trans-abdominal. If it is posterior, then I'll have to do a trans-vaginal procedure. The next procedure that I'm going to talk about will be chordocentesis. Now, chordocentesis is aspiration of the umbilical cord. So when I talk about aspirating a umbilical cord, I have to again aspirate a fluid, so I can use a thinner needle. So I'll be using a 22 gauge needle and I'll be putting it inside the umbilical vein. You of course remember that in my umbilical cord, I have two arteries and one vein. So I'm going to take it from this and not from these two. Why? Because remember that my umbilical artery will have a much thicker tunica media. It will have a lot more smooth muscles. So the moment I prick them, these muscles are going to get stimulated and that can lead to vasospasm. Vasospasm will contract the vessels, and you know that umbilical arteries carry blood from the heart, the fetal heart, to the placenta. So if they contract, the fetal heart will not be able to push the blood towards the placenta. This will lead to fluid overload and can lead to fetal bradycardia. As a consequence of fetal overload, excessive fluid inside the fetus, it will resort to bradycardia. Just like whenever you lose a lot of blood, when you have less of blood in you, you have tachycardia. Similarly, when you have a lot more of blood, you will have bradycardia. And fetal bradycardia is equivalent to fetal distress that can lead to intrauterine fetal demise. So chordocentesis is done only from umbilical vein, which will have a very thin tunica media and it is not going to go into vasospasm. So I'll be aspirating blood from it. Now, what are the reasons why I have to aspirate the blood from cord? One of the most important reasons is going to be in RH isoimmunized pregnancies when the MCA PSV is showing a peak systolic velocity is more than 1.5 MOM, 1.5 multiples of median, which is indicative of fetal anemia. So to confirm fetal anemia, I'll be taking a sample of blood. I'll be checking the hematocrit. A hematocrit of a normal fetus is between 60 to 70. But if it falls below 30, then it is an indication that you are having fetal anemia and you need to do intrauterine transfusion as well. So from the same needle through which I have done chordocentesis, I'll do again intrauterine transfusion. So I just keep that needle in situ. I do not let it move. And because the cord should not move, the point where I insert this needle is going to be at the attachment point of this umbilical cord, which is over here. I do not take the free loop which is lying open and the needle can come out from it. I'll be taking it from the fixed part that happens to be near the placenta. This is called as chordocentesis and it is often combined with intrauterine transfusion. This is a very important aspect that you need to know, that all these procedures, CVS, amniocentesis, and chordocentesis, if they are being done, there is a very high risk of feto-maternal hemorrhage. So, feto-maternal hemorrhage in a patient who is probably having RH negative pregnancy, of course, if it is isoimmunized already, then there is no point. But in other two, in patients who are just RH negative and not isoimmunized, in them you have to cover it with anti-D once you are done with the procedure. So this is about amniocentesis, chorionic villus sampling, and chordocentesis. Before I come to fetal procedures or fetoscopic procedures, I would want you all to tell me if you all have understood everything that I've spoken until now. Does anyone have any doubt until now? Any doubts? How was it done abdominally? Through open surgery? Yes. Someone has asked, how is trans-abdominal thing done? Of course, it can be done through an abdominal open surgery, that is a laparotomy, or it can even be done laparoscopically, which is in fact nowadays the more preferred modality if you're skilled enough to do it. Does anyone have any doubt with whatever I have spoken until now? Any doubts whatsoever? I'll insert an image over here. Any doubts? Does anyone have any doubts? Worm stitch. Oh yes, worm stitch, worm stitch. Yes. Sir, quality and quantification test. It is Curly Kiohar Bredke test. Worm stitch, yeah, good point that you mentioned, Shubhangi. Great. Worm stitch, that's a point that I just forgot to speak about. So, what's a worm stitch? In worm stitch, if this is my cervix, And if this is dilating, let us assume that it has dilated to 2 centimeters already. What I do is I take this Mercilin tape or an Ethilon, and I'll be taking one stitch from 12 o'clock to 6 o'clock, and the distance between both of them is going to be 1 centimeter. And the second stitch is going to be taken like this. So basically, I'm taking a cross stitch and I'm obliterating this area where the dilatation was occurring. While doing this, I can just use a pediatric Foley's or just a gauze piece on a sponge holder and push the membranes inside gently. I can also give a head low position, that is Trendelenburg position, to ensure that the membranes just retract a bit, and I can do this procedure. This is called as the worm's stitch or an emergency cerclage. The distance between this as well has to be 1 centimeters. This will temporarily buy me time from the fetus further, from the cervix further dilating, and of course, it will give me a very crucial period for me to administer the patient antenatal corticosteroid so that the fetal lung maturation can happen. I can also administer magnesium sulfate for neuroprotection in this period. So this will help me by a few very crucial days for pulmonary maturation of the fetus. It is not going to help me too much. It is only going to probably help me for a few days or maybe a couple of weeks, not more than that. So this is worm's stitch. Okay. So has everyone understood all these concepts until now? So now the next thing that I'm going to talk about is going to be a fetoscopic procedure. So over here, you can see how a fetoscopic procedure is being done. Now, what's a fetoscopic procedure? Now, fetoscopy, feto is fetus and scopy is a camera, wherein just like a laparoscope, I insert a camera inside the abdomen and I do this procedure. So under this, I can either do something like a laser coagulation, or I can do cord ablation, or I can do tracheal occlusion, and several more procedures. These are the few commonest. Now over here, you can see that there are twins, and you can see that one twin is having polyhydramnios and the other one is having complete oligohydramnios. So this is a very classical example of a monochorionic gestation with twin transfusion syndrome. Now the problem is, as we have already studied in a previous session, that the problem over here is the arteriovenous connection that is occurring over here. So what we do is we insert this fetoscopic probe and along the equator, that is from the midline, I cut down or I laser coagulate all the vessels in between so that the connection, the arteriovenous connection between both the fetuses is shut down. This is called as laser coagulation of the arteriovenous anastomosis. This is the treatment of choice done for TTTS, and the name of this technique is Solomon technique. Solomon technique is basically me doing it along the equator. This might need to be repeated again and again because the collaterals will develop and restart the twin transfusion syndrome. But this is how you will be doing laser coagulation. Cord ablation is basically I'm just ablating the cord of a fetus. This is a method for multi-fetal reduction. So basically, when there are 3 or 4 fetuses, or in second or third trimester, there's a fetus that turns out to be anomalous, and now I have no option but to ablate the cord. It is a monochorionic gestation, so I cannot give KCL, because if I give KCL inside the defective fetus, the fetus is going to send all that KCL to the other fetus as well through the common shared placenta, and that can lead to both the fetus dying from that KCL. Which is why all I have to do is I have to ablate the umbilical cord, the umbilical vein, and the umbilical arteries of that one fetus which is defective, that will selectively terminate that affected fetus. So that is cord ablation. Tracheal occlusion is basically I'll be occluding the trachea of the fetus which has congenital diaphragmatic hernia. So what happens is, in congenital diaphragmatic hernia, your bowel loops, your stomach, your liver is coming into the lung field. So it is compressing the lungs, and that is going to lead to pulmonary hypoplasia because they are not expanding. The lungs are not expanding. But I know as a fact that my lungs are secreting fluids. They do contain fluid that is excreted out through the bronchi, trachea, and then the mouth. That is, in fact, one of the ways in which amniotic fluid is produced before the kidneys take over the function at around 20 weeks. So what I can do is I can just put a obliterator or a cork or something that obliterates my trachea so that the fluid doesn't come out, and instead the fluid accumulates in the lungs, and those lungs swell up and they push the bowel loops back into their abdominal space. This will ensure that the lungs will not undergo pulmonary hypoplasia. This is called as tracheal occlusion, that is done for patients and babies with congenital diaphragmatic hernia to ensure that pulmonary hypoplasia, because pulmonary hypoplasia is the cause of death in these patients after delivery. Hence, this will help me push the bowel loops back and improve the pulmonary surface area. This is called as tracheal occlusion. And these are the major fetoscopic procedures that you need to know about. Now coming to the last antenatal procedure, and that is external cephalic version. Now, external cephalic version, very simply put, Uh, everyone understanding? Worm stitch, yes. No doubt. So worm stitch is it taken at external loss or internal loss? Worm stitch can only be taken at the external loss because the cervix has started dilating. So you cannot do anything. You cannot go till the internal loss because the membranes are already bulging. So only the external loss is left for you to take, which is why you will be using a pediatric Foley's bulb or a gauze piece to push the membranes inside. Is amnio infusion done in patients with oligohydramnios due to PPRM? No. It is pointless. In fact, by doing amnio infusion, you would end up exposing or introducing outer organisms inside. So it is pointless to do amnio infusion in them. And a lot of people do it, but I do not see any point of doing it because the membranes have ruptured. The amniotic fluid will keep flowing out. So it is of no use of doing that. Instead, you will be introducing and increasing the risk of chorioamnionitis. So talking about external cephalic version. So when I talk about external cephalic version, what is external cephalic version? Basically, whenever there is a patient, this is that patient, this is our abdomen, this is our uterus, and there is a fetus who is in breech presentation, and the patient wants to deliver vaginally. The patient tells me that she doesn't want to take a risk of delivering a beach baby vaginally because she has heard about head entrapment and all the hypoxic injuries, brain injuries. So she says that I want to have a trial of vaginal labor, but I do not want to do it in a breech presentation. So I will offer her external cephalic version. First of all, I'll ask her, are you a primigravida or a multigravida? For a primi, it is to be done because the uterus is less flexible. It is done at 36 weeks. Whereas in a multi, because the uterus is usually more roomy, I will do it at 37 weeks. Why? Because if I do for a multi at 36 weeks, because of the extra room, the baby will revert back to its breech presentation. Whereas in a primi, because it is less roomy and less flexible, less distensible, if I do it at 37 weeks of gestation in a primigravida, the chances of the procedure failing are higher. And in fact, I'll end up giving the baby, instead of breech presentation, I'll end up giving the baby transverse lie, which is why for primies it is done at 36 weeks and for multis it is done at 37 weeks. It is supposed to be done only and only in an operation theater. Do not do it in your OPD or ward. A lot of people do it, but it is pointless. Why? Because there is a risk of bradycardia, fetal bradycardia. Why would there be bradycardia? Because what if during the procedure, the cord, which was probably there around the neck, or while doing the procedure, that cord got pulled or it got compressed on the uterine wall between the baby and the uterus? That can lead to variable decelerations and even fetal bradycardia. And if there is persistent fetal bradycardia, more than 10 minutes, then I will have to deliver her by emergency cesarean section. So up to 10 minutes, it is acceptable. I will give her a left lateral O2, left lateral position, O2 by nasal mask. But if it persists more than 10 minutes, then I have to take her up for cesarean section. This is very classical for external cephalic version. Hence, I have to do this procedure in an operation theater. While I'm doing this, it is to be done under USG guidance so that I know what I'm doing and I know what is the fetal front and what is the fetal back. Also, I have to ensure that it is done under continuous cardiotopography monitoring so that I can note the decelerations, variable decelerations, and bradycardia. Apart from that, I can give a tocolytic because I'm handing the uterus so much now. For the people, for postgraduates who are watching this session, you all would know that whenever a patient has a postpartum hemorrhage intraoperatively, you start giving a uterine massage. Uterine massage is basically, or even after vaginal delivery, you do uterine massage. So what is uterine massage? Uterine massage is whenever you stimulate or touch the uterus rigorously, that is going to lead to contraction of the uterus. So similarly, when you are doing a ECV, that is external cephalic version, you are continuously touching the uterus so much that the uterus can start having labor pain, and labor pain or contractions are going to make my external cephalic version much more difficult because the uterus will start contracting and it will not give me the space that is required to rotate the baby, which is why a lot of people prefer to give a tocolytic prior to the procedure. It is most commonly a beta mimetic that is given subcutaneously, and the name is terbutaline. The dose is 0.25 milligram. So this is the drug that is given to patients. So tocolytic, it is optional, but a lot of people prefer to give it. Once this is done, there are two ways in which I can do it. If this is my fetus, it is lying like this with its legs like this, a very bad diagram, but okay. This is my upper and downwards. If this is the position, I can do two things. I can either make the baby, of course, these are the baby's eyes over here and the baby's nose over here. So what I can do is I can either do a forward somersault in this direction, or I can do a backward somersault. These are the two ways I can do it. Of course, the one that I will prefer is going to be my forward somersault. Forward somersault is going to be preferred. Why? Because it will maintain the flexion of the fetus. The baby is not going to get extended, because when you do a backward somersault, there is a chance that the fetal head might get deflexed. And if I'm going to make the baby's head deflex, then even if it becomes cephalic presentation, a deflexed head is going to have cephalopelvic disproportion and it will not deliver vaginally. Hence, a forward somersault is what is preferred as a technique of doing or the direction of doing this ECV, and hence the USG is going to guide me as to where is the fetal front and where is the fetal back. So forward somersault is done. Once I'm done with the procedure, if the patient is RH negative, I have to ensure that I give her anti-D. Remember that there are high chances that this baby is probably going to revert back to its original state, wherein if it does happen that way, I do not try it again. I will just tell her that it is in breech presentation. So now it is your call whether you want to deliver her vaginally or do an elective cesarean section. And the worst thing that can happen is it can stay in transverse lie, and you may have to take her up for emergency section if there are contractions, because any patient or any baby in transverse lie cannot undergo labor, because that will lead to cord prolapse, limb prolapse, all these complications. So this is what is significant that you need to know in external cephalic version. I mentioned about IP, that is internal podalic version. In internal podalic version, what I do is I hold the fetus legs whenever this is classically done for the second twin. So whenever in twin pregnancy, the first twin has already delivered vaginally. So the first twin is out, vaginal delivery ho chuka hai, and the second twin is probably transverse lie mein hai. So in that scenario, I will hold the baby, I will put my hand inside, I will pull the baby's legs and I will pull it out and I will deliver the baby by breech presentation. Remember, there is a risk of uterine rupture while doing this, a very high risk of uterine rupture, which is why this is nowadays considered obsolete. So IPV is done whenever the second twin is in transverse lie and I have to convert it to breech presentation. I will hold the limbs and I will make it longitudinal and try to deliver it by breech presentation. But uterine rupture is very high, so I have to be very careful, especially if the uterus is contracting, is having excellent uterine contractions that can lead to a rupture. This was about all the antenatal procedures. Before I proceed to intrapartum procedures, which will include my operative vaginal delivery first, let me know if you all have understood. We are exactly at the halfway point of this session. Has everyone understood this session until now? Let me know quickly so that I can go for the intrapartum part. When do you remove worm stitch? You remove the worm stitch when the patient is having probably leaking of membranes, or when you can see that the external is thinned out completely and now it will just lead to a tear. So we will remove it once the labor is trying to progress rapidly and the membranes are completely bulging out. I'll just put on the group that we are starting with the intrapartum. Okay. So does anyone have any doubt? If not, we'll proceed. Tocolysis in fetal procedures. Uh, Tocolysis in fetal procedures, yes, definitely. If you're, I would prefer to give them, because whenever you're inserting all these probes, it can lead to initiation of preterm labor, which I do not want. Hence, tocolysis, in my opinion, should be given. Tocolysis along with steroid cover should be given because there is always going to be risk of PPROM in all these procedures after 24 weeks, of course. And of course, you have to cover them with antibiotics as well to prevent any infections. Okay, so the next is going to be intrapartum procedures. So in intrapartum procedures, the first that I'm going to talk about is assisted, or what we also call as instrumental vaginal delivery. Now, whenever I talk about this, I have two ways. I have either forceps or I have vacuum. Now, whenever I'm talking about this, remember, for me to deliver a baby vaginally using an instrument, it's an added thing that I'm doing, which will entail with it a lot of maternal and fetal risks. It's a way of expediting delivery, and whenever I'm trying to fasten something or hasten something up, that is certainly going to lead to risk of some or significant, I would say, not even some significant maternal and fetal harm. So it has to be that there is an indication that is there for which I am going to resort to an assisted vaginal delivery. So what are the indications? The indications can be maternal or fetal. So in maternal indications, I would want to expedite the vaginal delivery when there is possibility of exhaustion of the mother is too exhausted with labor, so maternal exhaustion, or whenever I have to cut short second stage. What is cutting short second stage? Remember, in second stage, whenever a patient is bearing down, there's a lot of pain. That pain, that tachycardia will lead to reduction in the diastolic time of the heart. The diastolic part of the cardiac cycle is going to be reduced. Whenever the diastolic part is reduced, my cardiac filling time, the ventricular filling time will reduce. If the ventricular filling time reduces, the blood that should accumulate in the ventricle before it is pumped out will not accumulate, and instead there will be back pressure changes that start occurring because the ventricles are not accepting the entire amount of blood because it doesn't have enough time to accept the blood. This will lead to accumulation of all the blood and fluid in the lungs, and back pressure changes will initiate, and that will go on to lead on to cardiac failure or heart failure. So I do not want to precipitate heart failure in a patient who already has heart disease. Hence, in those patients, I'm going to cut short second stage of labor. Also, in patients who have severe anemia and whom I'm just transfusing blood, the body's oxygen carrying capacity is very low. So in those patients as well, I do not want to risk her having excessive tachycardia because of lack of oxygen carrying capacity in our body, is when I'll be doing this cutting short of second stage of labor. Apart from that, if there is complete non-cooperation from the patient, uh, most likely if the patient is a post-eclamptic patient in a post-ictal phase and confused state and she's not cooperating at all, or she's just not responsive, she's an unconscious intubated patient, in that scenario, I'll be using one of these assisted vaginal techniques. For fetus, there can be something like arrest of labor or arrest of descent, which occurs in second stage. So basically, the cervix is fully dilated, but the head is not coming down. It is stuck at a stagnant position for a stipulated amount of time. In a primary graviditis, more than 2 hours, and in a multigraviditis, more than 1 hour. Then I'll resort to instrumental vaginal delivery. Or if there is fetal distress in second stage, fetal bradycardia or tachycardia. Apart from that, uh, if there is any problem like there is aftercoming of head, basically the aftercoming head in a breech presentation. So once the baby's breech is delivered in breech vaginal delivery and the head is coming out, the head can get entrapped. So in that scenario, I can use a forceps and I can pull the baby out so that the head doesn't get entrapped. So these are the indications for me to be using a forceps. Indications are the reasons why I need to use forceps. Once one of these indications are ticked or fulfilled is when I'll go ahead and look at the prerequisites. That is the difference between prerequisites and indications. Indication comes first. I have to first ensure that there is some indication, and then only I can go ahead and then start checking whether the prerequisites are fulfilled as well. So just like indications, there are maternal and fetal prerequisites. The maternal prerequisites include, first of all, The bladder should be empty so that the bladder is not pushing the anterior wall downwards, and I have adequate amount of space to apply the instrument. Apart from that, of course, because I'm inserting instruments inside her, it can be very painful. So I have to give adequate analgesia. It can be a pudendal block. It can be a paracervical block. Difficult, but yeah, you can give it. Or it can be something as simple as a perineal block that you give for your local episiotomy. You have to definitely take the consent. The most important point, I should have mentioned this first. If the patient is not willing, if you tell her ki in Hindi ki chimta lagane wala, we are going to apply forceps for your baby, and the patient just says absolutely no, then you cannot go ahead with that. So consent is very important, and your cervix should be fully dilated. You cannot apply any instrument at partially dilated cervixes. There are people who say that vacuum can be applied at 8-9 centimeters. Do not do that, because if you do it, you will end up having very bad annular cervical tears, which are very difficult to suture. You will end up having a traumatic postpartum hemorrhage. So do not attempt that. And lastly, the membranes have to be ruptured. The amniotic membrane has to be ruptured so that I know what is the exact station, what is the exact rotation of the fetus, and so that my instrument doesn't slip off. So membranes have to be ruptured. From the fetal point of view, I need to know that the baby should have no coagulation disorders if I'm using a vacuum, or there should be no skeletal problems like skeletal dysplasia or osteogenesis imperfecta in a patient in whom I'm using forceps, because that can lead to further fractures. Also, the baby cannot be premature if I'm using a vacuum. So preterm babies में vacuum नहीं use कर सकते, that will lead to intracranial hemorrhage. Apart from that, I have to know the station, and the station has to be 0 or more. So 0 और 5 के बीच में होना चाहिए, and there shouldn't be any cephalopelvic disproportion. And I should, of course, know the rotation of the fetus. So these are the prerequisites that have to be fulfilled before I go ahead and use an instrument. So these are the indications that have to be fulfilled first, followed by पहले indications होने चाहिए and then prerequisites होने चाहिए. When both of them are ticked, indication can be any one of these, but prerequisites, all of these have to be fulfilled. Even if one of them is not fulfilled, you cannot go ahead with the instrumental delivery. So the first instrument that I'm going to be talking about is a forceps. Now, a bit about how and when this forceps were initiated. The earliest mention of forceps is 1200 BC. Of course, there is no mention of who was the one who used it, but a use of forceps or a use of an instrument that was used to deliver a fetus vaginally. The first mention is found in a few Sanskrit texts that date back to 1200 BC. But it was not until 16th century by the Chamberlains who actually developed a sophisticated forceps for vaginal delivery, but they kept it to themselves for the next 100-150 years until 1752, wherein Smelly. Now you know Smelly by that breech, Mauricio Smelly Valley method, MSV method of delivering the head of the breech. So Smelly was the one जिसने forceps के अंदर lock and shank introduce किया. I'll be telling what are these parts. Lock and shank was introduced. Very important. Lock would prevent the two blades from slipping apart or falling apart, and shank is something that gave length to your instrument. So it was introduced in 1752. After that, in 1747, Leverett introduced the pelvic curve. I will show you what the pelvic curve is to the forceps so that it can glide easily on the angle of carus of the sacrum. I'll be showing all these parts. In 1915, almost 200 years later, the first important person, the first important name came into the picture, that was Keeland, wherein he made the rotation forceps, which are now called as the mid-cavity forceps. Then, in the year 1929, came the second important person, that was Piper. Piper's forceps, which are used for the aftercoming head of breech. And then in 1935, it was Wrigley who introduced a short forceps. And lastly, All these forceps that were used were completely made of stainless steel. So in the year 1937, Leucart introduced a pseudo-fenestrated forceps to reduce the weight of the instrument. What we use today are true fenestrated forceps. So, what are the parts of forceps and which are these forceps that I've mentioned? So over here you can see a few important ones. The first one is a Simpson brawn. You can just call it Simpson. The parts of the forceps before I go ahead are एक तो जो अंदर का रहता है, the part that is inside. If this is your forceps and if this is your internal part where the fetal head comes, so this internal side is called as the cephalic curve. Whereas this side, when you see it from the side, this side, the side below, जो ये नीचे का side है, this is the pelvic curve. Remember, a lot of people say that this is the pelvic curve. Behind this is not the pelvic curve. This, where you can see my little finger, is the pelvic curve because this pelvic curve is the one that is going to run on my pelvis and going to deliver the baby. So over here, if you're going to see this, you see that this is the pelvic curve. Whereas जो इसके अंदर का साइड है, ये जो बीच का साइड है दोनों का, दैट इज माय केफेलिक कर्व जिसमें बेबी को मैंने ट्रैप किया हुआ है. सो दे आर बोथ इन परपेंडिकुलर प्लेन टू ईच अदर एंड दे आर नॉट आगे एंड पीछे. सो दे आर इन परपेंडिकुलर. Then this is called as the blade. This is the pelvic curve. This is also called as the toe. Then this is the shank. This entire thing is the shank. Shank is what increases the length of your forceps. Over here you have your lock which will prevent the slipping away, and then you have your handle and screw. Screw to ensure that the lock and this entire instrument stays in place and it doesn't separate out. Now, when you talk about these instruments, a few important ones that you need to know are Simpson's forceps. How do you know the Simpson's forceps? A lateral process which is there. This is very important. This is going to help you in your exams. And of course, this design over here that you can see for better handling of your forceps. This is a Simpson's forceps. Apart from that, the Wrigley's forceps does not have that lateral process. उसमें नहीं है, and the length of the handle is also very small. So Wrigley ka very classical feature is it is going to be smaller in length, small shank, small handle, and no lateral processes. Whereas in keel and forceps, you will see that in all these, you could see that they were parallel to each other, but यहाँ पे they are not parallel, they are overlying each other. You can see they both are overlying each other. The two blades are overlying each other, and there is a sliding lock over here. There's a lock that you can see that will slide, and also there is a distance between both these handles so that I can slide them easily, which is why this is also called as a rotational forceps. There's a special type of forceps over here that is your Piper's forceps. Your Piper's forceps have a very long shank. This is the longest possible forceps, and this long shank is also going to have a curve like this. This curve is called as the perineal curve. Just like there was a pelvic and cephalic curve, यहाँ पे there is a pelvic perineal curve. Why? Because it lies over your perineum. Your baby is going to rest on this. If this is your breech, your entire baby's body is going to rest on this part. इसलिए ये perineal curve पे पूरा body रहता है, so that this can go in and it can trap the fetal head and it can deliver it out. So this is the perineal curve, which is very classically seen only and only in a Piper's forceps. These are the parts. Now, how do I apply it? Before knowing how do I apply it, I need to know a few basics about what are the various parts. So in blades, you could see over here. Do I have a picture? Do I have? No, I don't actually have a picture. So just assume if this would have been completely filled with metal, with steel, like this would have been a solid forceps. So the blades can be solid, or there can be a depression in them called as pseudo fenestration, or it can be a complete hole in them like we have all our regular forceps, that is a fenestration. In that, the Tucker and Maclean are the solid forceps which are no longer used, very heavy. Pseudo-fenestrated was Leucart, whereas fenestrated are all the ones that we use today, which includes my Wrigley, Simpson, Keeland, and Piper. All these are fenestrated forceps. Fenestration is basically this hole that you can see. This hole is going to help me accommodate the fetus better and also reduce the weight of my instrument. After that, after knowing about the blades, I have to know about the shank, which I've already mentioned, the perineal curve. Then I am having my handle and lock. So the lock can be of various types. It can be English lock. I've already taken a session on this. I've shown each and every lock. I'm not going to be talking about it again. There can be German lock. There can be a sliding lock as we see in Keeland's forceps, and there can be a pivot lock. Apart from that, how do I apply it? So there are levels of applying the forceps. So high forceps, which are completely obsolete now, mid cavity forceps, and low forceps. Under low, I have outlet forceps. So if the station is either 0 or +1, I'll be using mid cavity forceps. Remember that my pelvic inlet is in the transverse diameter, it is maximum in its dimension, and the pelvic outlet is in the anterior posterior diameter, the longest dimension. So the fetal head has to rotate, has to engage transversely, and then it has to rotate towards the anterior pole, and then it has to deliver. So the occiput has to rotate from transverse to anterior and then deliver. This rotation is not going to occur when the baby is at 0 to +1 station, and hence at that position you may have to forcibly rotate it, for which you will be using the rotational forceps or the Keeland's forceps. So those mid cavity forceps are classically your Keeland's forceps. I've already made a couple of videos on mechanism of labor using a pelvis. You can check out our social media pages. I have made those videos. Whereas in the low forceps, I'll be using it when the station is +2 or +3 or +4 or +5, anything, but more so +2 and +3. Whereas the outlet forceps is when the head is already stretching the perineum and it is crowning. So +4 and +5, when the head is stretching the perineum, the vulva apart, is when I'll be using the outlet forceps. Why do I need to know the level of applying it? Because that is going to tell me in what direction do I have to move. So higher the location, remember that anteriorly you have your pubic symphysis and posteriorly you have your sacrum and the coccyx. So if the head is at a higher location, you have to bypass both of them. So your direction will have to be downwards. Whereas if the station is over here, you do not have to bring it downward. You just have to pull it upwards and outwards. To bypass these two bony prominences is why you need to know the direction. And you can see over here, if your station is at the highest, then the direction is going to be downwards. The moment it starts coming lower, you'll be pulling it outwards, and then finally you will be pulling it this way. This movement is called as initially downward and forward direction, and lastly upward and forward direction at the end of it. So this is determined by the station at which you are applying your forceps. Now, how do I give traction? This traction is by the Saxtorph-Pajot maneuver, in which you see that this is your left hand and this is your right hand. With the right hand, you're holding the handle, and with the left hand, you're holding the shank. This left hand is pulling the forceps downwards, whereas this right hand, which is on the handle, is pulling it in a forward direction. You require both these forces coming forward and downward to get an adequate traction and the direction of the pulling. And this maneuver is called as a Saxtorph-Pajot maneuver, wherein one hand is going to be like this and the other one is going to be like this. So with this, I'm going to pull it down. The shanks are going to be pulled down, and with this, I'm going to pull it outwards. So a combination of this is going to make it come out this way. This is the Saxtorph-Pajot maneuver that I had mentioned in the message prior to the session. Did everyone understand this part of forceps, the Saxtorph-Pajot maneuver? Before I move on to vacuum, did everyone understand this concept? Does anyone have any doubt with this point until now? What are the doubts? Are the same dosing guidelines for MMA applicable in previous LACs, or should it be? That's a good question. I'll come back to it. I'll come back to it. Uh, So are the same dosing guidelines for MMA applicable? Yes. No. I mean, actually, in first trimester until 12 weeks, you can use the same doses of misoprostol. But in a later gestation, that is in the second and third trimester, I personally prefer to half the doses that are given in the misoprostol ka guideline, the FIGO guideline. Although the FIGO guideline doesn't mention that you have to do this, they only say that keep an eye on scar tenderness. But I personally prefer to half all the doses after 12 weeks of gestation to avoid the risk of uterine rupture. Did everyone understand this topic until now? Any doubt whatsoever? Any doubts? If there is any doubt, let me know so that I can talk about it. Now coming to the next procedure, that is everyone understanding the session? I am trying to summarize all the points. Of course, these are individual topics. All these 30, 35 surgeries that I'm or procedures that I'm talking of are individual surgeries. So it is impossible for me. It will take me 30 hours because it's a topic that I can speak on for an hour each. So I just hope everyone has understood whatever I've spoken until now. And please let me know if you all have any doubts. I hope you all are liking the speed at which I'm teaching. I'm just speaking on the major important points that you need to know. Okay. Now coming to the next instrument, vaginal instrument, and that is my vacuum or ventouse. So similarly, a quick history. 1708 was the first instance when this was started by James Young, the Young stitch, the same person. After that, in 1848, almost 150 years later, it was Simpson, the same Simpson who had given me my forceps, who said that I'll use a piston to pull to generate a vacuum. After that, in 1956, almost 100 years later, Malmstrom came with the design, roughly the design that you use today. And finally, in 1984, there was introduction of the Scyllastatic cups by Apuzeria and Pelosi. So 84 में Scyllastatic cups का introduction हो गया था. So what is a Scyllastatic? Scyllastatic is silicone, hardened silicone. So what are the various types that I have with me? So it can be either metallic, or it can be scyllastatic or rubber, hard rubber, good quality rubber, or it can be in the form of a kiwi cup, and it can be Mitivac. Mitivac is a registered name. It's a registered name, copyright सब उनका है Mitivac company का. So just to show you the diagrams of how it looks, over here you can see, yeah, over here you can see the first thing that this is a scyllastatic one. This is hard एकदम rubber का है. The next one is going to be metallic, and this metallic has its own set of complications. Of course, there's a higher possibility of the rubber slipping off during the procedure. The metallic has a higher chance of delivering the baby successfully, but it also has a higher chance of causing head injuries, cookie cutter injuries. I had a picture. If you all want to see that picture, just message me. I have a picture of a baby who has suffered a cookie cutter injury. Cookie cutter injury is basically that metal had pulled off all the scalp from that particular circular region of that baby's head. So the baby was referred to us in that state when the scalp was completely denuded. It was completely removed. That is called as a cookie cutter injury. Metallic कब से होता है? Baby deliver तो हो गया, but at what cost? I do not want the baby to lose a complete scalp का part and be bleeding when it comes to me. So no, metallic cup बहुत अभी कम लोग use करते हैं. And this what you can see is a kiwi cup. Kiwi छोटा सा cup. ये इसके ऊपर जो दिखता है, इसके ऊपर प्रेशर दिखता है, and this you put your fingers over here and you press it in this direction and then you pull it. So basically इससे वो vacuum बनते जाता है. इसमें you can see how much of vacuum or pressure has been created. This is a measurement over here, and this is your cup, and this is my Mitivac. So Mitivac में ये यहाँ पे उंगलियां रखूंगा. I'll keep my fingers over here and I'll generate the vacuum. यहाँ पे there is this meter that I can see how much of vacuum has been created, and this I will help. This is the cup which I will be attaching on the fetal head. Now, whenever I'm attaching this, there can be various places at which I can attach this. I have to attach it at the pivot point, on the flexion point, or these are the various ways in which I can attach it. The best way and the only way, in fact, is this, that is the flexing median. Why flexing median? Because when you talk about the baby's head, when you talk of this point, that is the flexing median over here, when you pull it, you have to remember that this point aligns along the axis of the body. Hence, when you pull it along this direction, the baby's head will stay flexed and you will be able to exert traction on the entire body and pull it out. Whereas, if if you're going to apply it anywhere anteriorly, that is something like deflexing median, you're going to apply it anteriorly, then the head is going to be pulled backwards. There is going to be extension of the head, and then it is going to be pulled out. This extension is going to increase the engaging diameter. Hence, you have to apply it at this point. This point is going to be 3 centimeters ahead from the posterior fontanelle and 6 centimeters, the center of this point, by the way, the center is going to be 6 centimeters posterior to the anterior fontanelle. This is my anterior fontanelle. Here it was my posterior fontanelle. So 3 centimeters anterior and 6 centimeters posterior. The flexion point or the pivot point or the flexing median point. One more bad thing that you can do is you can apply it on one side, that is on one parietal bone. This will lead to asynclitism, that will lead to this lateral flexion of the head. Again, that will increase your engaging diameter and the baby is not going to be delivered successfully. And the worst possible is deflexing paramedian. Everything has gone wrong. It is neither in the center nor is it applied over the flexion point. So everything that has gone wrong has happened over here. So this is how you'll be applying a ventouse. To talk a bit more about ventouse, I have to know that initially I have to apply at a vacuum or a pressure of 100 milligram of mercury, which is almost equivalent to around zero point 0.2 kg per meter square. Then I have to gradually increase over 1 to 2 minutes. A few books even say 5 to 8 minutes, but 5 to 8 minutes is a lot. Over 1 to 2 minutes, you have to gradually increase and you have to take it to a maximum of 600 milligram of mercury. A few people even say 660, but 600 is ideal, or zero point 0.8 kg per meter square, depending on whatever units are given on your machine of vacuum creation. This is how you will be increasing it. Now, here is a very crucial point that you need to know about. Remember that over here, you're at least taking 1 to 2 minutes for increasing the vacuum. Now, if your fetus is having distress, you cannot be wasting 1 to 2 minutes because each and every second is putting the baby more towards hypoxic ischemic encephalopathy. Basically, hypoxic brain damage ke chances are going to increase the more you wait upon it, which is why whenever you have a fetus with fetal distress, the instrument that you're going to use is going to be preferably a forceps wherein you do not have this latency of 1 to 2 minutes. You can directly just apply and pull it out. A lot of people do not wait for these 1 to 2 minutes. They just directly apply, they increase the vacuum and they pull it out. But even then, remember, utna vacuum बढ़ने के लिए at least 15 to 20 seconds जाते हैं. And second, if you're very drastically increasing at a drastic rate, you're increasing the vacuum, that can lead to rupture of vessels inside the fetal scalp, leading to cephalomatoma. And even inside the head of the fetus, there are going to be vessels that rupture that can lead to conjunctival hemorrhage, retinal hemorrhages, intracranial hemorrhages, which is why they often say do not increase the vacuum very rapidly. So a true fetal distress ka instrument is always going to be preferably a forceps rather than a vacuum. Of course, the chances of delivering with a forceps are also much higher than that are with a ventouse. If you try to pull and you have three pop-offs मतलब वो वैक्यूम का जो कप है वो निकल गया कैसे समझेगा? There is a hissing sound that you hear whenever it is coming off. This is indicative of some problem. You probably have attached it in the deflexing median or deflexing paramedian or flexing paramedium, which is why that sound is coming. So you have to understand that the placement is wrong, or probably the fetal head position is a little deflexed and you are not able to hence apply it. Do not waste time, directly go for cesarean section. A lot of people ask, can we do sequential application? Idiots, do not do this sequential application. A lot of people do it, vacuum lagate hai, wo fail ho gaya to forceps lagate hai. No, in this case what you will do is you will end up giving the patient complications of both the instruments and that can be disastrous. So अगर vacuum से नहीं आ रहा है, then समझ लो कि there is some CPD or there is some problem with the application. Probably the head is not has not descended enough, or probably the head is extended, deflexed है, कुछ तो problem है. Do not assume that फिर forceps लगा के निकलेगा. निकल सकता है, but the risk of genital tract trauma, fetal damage, ये सब बहुत ज्यादा रहेगा. Probably you have assessed the rotation wrong. इसलिए वो लग नहीं रहा था. All these factors come into play. So if there are three pop-offs, do not go and apply forceps. Directly take the patient for lower segment cesarean section. The complications, plenty of them. If I'm going to be talking about the complications, so forceps के complications क्या है and vacuum के complications क्या है. So forceps के complications, there are going to be maternal complications and fetal complications. Similarly, vacuum में there are going to be maternal and fetal complications. So maternal complications में you will have genital tract trauma. I'm going to come to that. I'm going to talk about the latest guidelines in genital tract suturing. There can be incontinence if you're damaging the pubocervical fascia or the denomvillous fascia posteriorly. So incontinence, fetal or urinary, both of them. And if it is too much, it can even lead to a fistula, rectovaginal or vesicovaginal fistula. For the fetus, in a forceps, you can have facial nerve palsy. अगर बहुत ही यहाँ पे तो facial nerve का ये जो tract है, if your forceps का blade presses too much on it, so there can be facial nerve palsy. Apart from that, there can also be possibility of a depressed skull fracture because you're pressing, if you're not choosing the right size of forceps, so there can be a fracture of the fetal skull because of the compression, forcible compression. And if it fails, then it can even lead to hypoxic ischemic encephalopathy. Also, if you by mistake apply it and the blade comes on the eye, there can be corneal abrasions. The cornea can get abraded. For vacuum, the maternal complications are not much. The most important is cervical laceration. If you have not assessed the cervical dilatation, and if you end up taking the cervix or the vagina, either of them, so that's a major complication. And vaginal tears, these are very common in the fetus. There can be Kefal hematoma due to rupture of fetal vessels between the scalp and the bone, then the periosteum. ये दोनों के बीच में there is going to be blood accumulation. Apart from that, you can have conjunctival and retinal hemorrhages as well, and intracranial hemorrhage if it is applied in a preterm fetus. So these are all the complications that can arise out of vacuum and forceps. So be very careful in using it. That is it about assisted vaginal delivery. Now I'll be talking about the next form of intrapartum procedure, that is cesarean section. So cesarean section, I'll be coming to perineal tears. Has everyone understood everything over here? Any doubts? I'm talking about all the cesarean sections now, all the rare types of cesarean sections that I know of. Any doubts whatsoever? I'll just check the chat. कोई doubt कोई पूछा है क्या? Okay. So now we are nearing the end of the session actually. So talking about cesarean sections. So whenever I do a cesarean section, I need to know that the first thing that I do nowadays is a fan and still incision लेता हूँ मैं सबसे पहले. Fan and still incision is on my skin. It's a 2 finger breadth ऊपर above the pubic symphysis is a transverse curvy linear incision. It's a very classical curvy linear incision that I take. And then I open all the abdominal layers, and when I reach the uterus, I take a Kerr's incision. A Kerr's incision is a transverse lower segment incision. And then I deliver the fetus and I deliver the baby, and then I can close it back after placenta is removed. And this is the regular cesarean section that I do. What are the variations that I know of in a cesarean section? One of the variation that I need to know is going to be what are the various incisions that I have. So the latest guidelines say that you should use a JC incision, that is Joel Cohen incision, Joel Cohen, Joel Cohen incision, which is taken 3 centimeters above the line that joins both the anterior superior iliac spine. So 3 centimeters above the imaginary line that joins the anterior superior iliac spine. उसके ऊपर 3 centimeters रहने वाला है. And of course, it's not curvy linear, it is transverse. Next, they say the method of doing the surgery should be Misgaw Ladakh. Misgaw Ladakh is a technique wherein once you have opened the skin, You only dig in the center, you only take incisions in the center because laterally you have your superficial epigastric vessels. So you only dig in the center, and then when you reach the rectus sheath, you vertically open it up. So basically, you're not going till the lateral ends, and hence the blood loss is significantly reduced, and you're doing blunt dissection inside. Also, it says that once you're done delivering the fetus, do not close the peritoneum, neither the visceral nor the parietal peritoneum, because they say that the peritoneum is going to reepithelize back within the next 5 to 6 days. So it will reepithelize back and then close it. So this will even reduce your post-operative pain because of the peritoneal closure. The stretching of the peritoneum can lead to peritoneal pain, abdominal pain, post-operative pain, and also it will reduce your operative time and blood loss overall. So this is the Misgauss-Ladakh technique that is advocated nowadays by even RCOG. So Misgauss-Ladakh technique with Joel Cohen incision is what is indicated. What I prefer to do is fan and still with Misgauss-Ladakh technique. This is the combination that I use. Are there any variations in the Kurz incision? I can have multiple variations. I can first possibly take a classical Caesarean incision, which is a vertical incision in the midline on the uterus. Of course, it is going to be a vertical incision that I take for patients with placenta accreta or with lower segment fibroid or cervical cancers or if I have to take any conjoint vein, I have to deliver a conjoint vein, is when I'll take a classical section. High risk because a thick, dense myometrium in the upper segment is going to be opened up. So to suture it back is going to be very difficult and it will lead to difficult hemostasis. So classical incision, not really recommended. The other option is if my Kurz incision is inadequate, then I can take a J-shaped incision. J-shaped incision is basically when the incision is not adequate. If this was my uterus, if this was my regular lower segment, that is my Kurz incision. So because probably the baby is macrosomic or baby is in transverse lie, I extend the incision laterally like this. This is a J-shaped incision. If even that is not adequate, then I make it a U-shaped incision. This is an acceptable way of increasing the length of my incision. What is not acceptable is a T-shaped incision, which is like a very terrible thing to do, wherein you have already taken a Kurz incision, but because it was not delivering, you took a vertical midline. So now you have almost done a classical plus Kurz incision together, and it is going to be very difficult to achieve hemostasis in this. So do not do this. If you have to extend it in a J fashion or a U fashion, because the myometrial density over here is lesser than the myometrial density in this segment. Lateral extent kam rahega. So J or U is to be preferred over inverted T incision. A variation to Caesarean section that you all have probably not heard of is an extraperitoneal Caesarean section. What is an extraperitoneal Caesarean section? Extraperitoneal Caesarean section is done in patients who have chorioamnionitis. In this, I do not open the peritoneum. Now, you of course know that whenever I open the abdomen, I'll be opening the parietal peritoneum, then I'll be incising the UV fold, that is my visceral peritoneum, and then incising the lower uterine segment. In an extraperitoneal Caesarean section, I'm not opening the peritoneum. Why? Because if my chorioamnionitis, basically my amniotic fluid which is infected, spills into my open peritoneum, that can lead to sepsis and septic peritonitis. I do not want that to happen, which is why in extraperitoneal Caesarean section, if this is my abdomen, if this is my umbilicus, I'll be taking an incision that is slightly paramedian. I'll be taking a vertical midline paramedian incision. Then I'll be deepening the layers. Once I reach the rectus muscle, these are my two rectus muscles over here. I'll be incising the rectus muscle of one end. And when I reach the peritoneum, bluntly, I'm going to dissect the peritoneum to one end. Now, if I'm going to see a sagittal view, if this is my bladder, if this is my uterus and this is my rectum, the peritoneum is literally like a balloon. So it comes over here, it goes over here, it goes over the rectum, and then it goes upwards. So all I'm going to do is I'm going to, without opening, in a normal cesarean section, I open it over here and then I open it over here. But in this, I'm not going to do that. I'm not going to open the peritoneum at all. Instead, I'm going to reflect this peritoneum to one side. I'm going to reflect it to this side. I'm going to pull it to this side. Then I'm going to put a retractor over here so that the peritoneum doesn't come in my incision. And then on the uterus, I'm going to take a J-shaped or a hockey-shaped incision like this. And from there, I'm going to deliver the baby. Now, the problem with this extraperitoneal cesarean section is that, first of all, I'm doing a slight bit of classical section जैसा है, J या hockey stick incision ले रहा हूँ इसलिए. Secondly, a problem with this incision is that in today's age and era, I have options of having higher and broad spectrum antibiotics at my disposal. So the risk of peritonitis is anyway very low. And hence, I do not need to resort to these techniques to ensure that peritonitis doesn't happen, because it will anyway not happen. I do not need to really worry about it, which is why Joel coin is above the level of between the two superficial anterior superior iliac spines, 3 centimeters above. Yeah. So this is called as extraperitoneal cesarean section, wherein I've operated entirely and not opened the peritoneum, which is like a balloon at all. I've taken it to one side, taken the incision, and then reposited it back to make sure that I recognize the bowel. A few people even inject methylene blue inside so that they can recognize the bladder, and then they can start pulling the UV fold away from the incision side. This is called as extraperitoneal cesarean section. One of the types of extraperitoneal cesarean section is the Waters, EG Waters. It's the name of an obstetrician, EG Waters cesarean section. So this is about cesarean section. Now coming to P-TES. Yes, someone had asked about episiotomy. This is going to be my next topic. Oh, by the way, before I go there, a few special scenarios are when the second stage LACS is going to be done, either because the baby is in second stage. The second stage is basically after full dilatation of the cervix, but before the fetus is delivered. When the station is too high, if the station is above zero and I cannot apply any instrument, or I'm not confident enough with with an instrument, or the instrument has failed. In that scenario, whenever I do a cesarean section, if this is my pelvis, and if this is my fetus, it is quite deep into the pelvis. जो normally मेरा baby इधर होता है head उसका ऐसा, but instead now it is completely down. This is what we call as deeply engaged head का cesarean section. Now in this, I have two ways in which I can do the cesarean section. The incision on the uterus is going to be over here. Now this incision is where the baby is completely down. So either I can push the baby upwards using an assistant's hand, or I can just pull the baby upwards from the incision. So this is divided into the push or the pull technique. Now, I do not believe in the push technique much, because remember that whenever the head is getting engaged, it has probably rotated. So if you're trying to just push the baby upwards, you're not derotating it, you're just trying to push it upwards, and that is going to make it very difficult to disengage. Secondly, जो vagina का पूरा infections है, they are going to come with the hand of the assistant into my operative field, leading to a chance of puerperal sepsis. And plus, with that much of handling of the fetal head, it can lead to cephalohematoma and intracranial hemorrhage. Instead, I prefer to do pull technique. Pull technique mein I have two things that I can do. I can either do Patvardhan's method. I have posted a video of Patvardhan's technique on our app. It is exclusively for subscribers. Or I can do reverse breech extraction. So basically, if the back is anterior and the hands and arms are posterior, so basically the back of the baby is anterior towards the incision site, then I will first remove both the arms, then I will remove the torso of the body of the baby, and then the limbs will come out. Whereas in reverse breech extraction is when the back is posterior, the back is on the sacrum of the mother, and the front side is on the incision. In that scenario, I will put my hand inside, I will pull the legs, and then I will bring the baby out. This is called as reverse breech extraction. Why reverse breech? Because in a normal breech, the breech would have been in the lower side of the uterus, whereas here the breech is upwards, which is why I'm doing reverse breech extraction. So reverse breech is done for back posterior, the back of the baby being posterior, and Patvardhan's technique is done and the back is anterior. I have posted a video of both of these on our app. There are several such clinical videos that we have, and they are on the app. You can watch them there. Now coming to vaginal deliveries and perineal tears. So whenever I'm going to be talking about perineal tears and episiotomy, the first thing that I need to know is these perineal tears have been given a classification called as the Sultan's classification. Sultan sir is a great man. He has devised every possible way to deliver a baby vaginally. So in grade 1, I'll be showing you pictures instead. So over here you can see this is grade 1 on Sultan classification, wherein there is only tear of the vaginal mucosa or the perineal skin. This is grade 1. In grade 2, there is tearing of these. You can see superficial transverse perineal. So perineal muscles are being torn, superficial perineal muscles, but not the anal sphincters. This is grade 1 plus this perineal muscle tear is grade 2. Grade 3A, grade 3B, and grade 3C. In grade 3A, you can see that this is your external anal sphincter that has been partially torn. So less than 50% of external anal sphincter has been torn in addition to grade 1 and grade 2 already. You can see that mucosa is gone, the perineal skin is gone, and also your superficial transverse perineal. Your perineal muscles are also gone. But less than 50% of the external anal sphincter is torn is 3A. If more than 50%, you can see over here, more than 50% of your external anal sphincter, if it is gone, then it is called as grade 3B plus, of course, grade 1 and grade 2. And finally, if your entire external anal sphincter is gone along with your internal anal sphincter, so if your internal anal sphincter plus your external anal sphincter is completely gone, that is grade 3C. And lastly, you have your grade 4, wherein even your rectal mucosa is gone. So internal anal sphincter plus external anal sphincter plus rectal mucosa, disastrous outcome. This is called as grade 4 perineal tear. So grade 3, A, B, C, and grade 4, these two are called as obstetric anal sphincter injuries, OASIS or OSC, external anal sphincter injuries. Now, first of all, I need to know how do I suture them. So first of all, I'll see अगर ग्रेड 4 टेयर है, as you can see over here, there is a grade 4 tear in here. Yeah, यहाँ पे grade 4 tear है, where you can see that the rectal mucosa has been torn. You see that the rectal mucosa has been torn completely, and this is your rectum, your anus over here. So to suture this, I shall be taking a suture, preferably 30 Vicryl or polygalactin as we call it. So 30 Vicryl is going to be taken, and it can be sutured in two forms. It can either be sutured in a continuous pattern or it can be sutured in interrupted pattern. Over here you can see we are using the continuous technique of suturing this rectal mucosa together. Once this rectal mucosa has been sutured, then is the time for a white glistening structure called as the internal anal sphincter. The internal anal sphincter can be sutured with 20 Vicryl or 30 PDS suture material. I prefer to use 20 Vicryl. Again, this can be done in continuous or interrupted fashion. It can be done in both. Remember to take continuous non-locking, because if you take continuous interlocking, that is going to lead to ischemia, that is going to lead to ischemia of the tissue, and that will lead to rectovaginal fistula. So never take a continuous interlocking, because that interlocking is going to obliterate the blood supply to these edges and it will not heal. Instead, it will give rise to rectovaginal fistula. Finally, once this is done, you have to suture the external anal sphincter. Now, the external anal sphincter is going to be classically described as a beefy red muscular stout structure. Beefy red is their appearance, whereas for internal anal sphincter it was glistening white structure. Beefy red is your external anal sphincter. There are two ways of doing it. One is you have your two ends, you attach them end to end, or the other way is you override them, that is called as overlapping. So you either have end to end or overlapping. Now, overlapping is said to increase the external anal sphincter tone, and that can lead to difficulty in defecation, which is why end to end is what is preferred. So over here, you can see how they have done end to end. So first of all, you can see that एंटीरियरली उन्होंने सबसे पहले पोस्टीरियरली उसको सूचर किया, देन सुपीरियरली किया, उसके बाद में एंटीरियरली किया, एंड देन इंफीरियरली किया है सूचर. सो बेसिकली दीज वर द टू एंड्स. देन सबसे पहले पोस्टीरियरली दे टुक अ स्टिच, सो दिस वाज पोस्टीरियरली अटैच्ड, देन दे टुक अ स्टिच सुपीरियरली, देन दे टुक अ स्टिच एंटीरियरली, एंड देन inferiorly, and then this was end to end anastomosis that was done for the external anal sphincter. And once that was done in continuous interlocking fashion, the muscle layers were sutured, and finally the skin and the vaginal mucosa was sutured. This can be done with 10 or 20 Vicryl. Remember, this is the only layer, the external anal sphincter, where you prefer interrupted sutures. Continuous करोगे तो stretch होगा, pull होगा, that can lead to dyssynergia. Whereas यहाँ पे again you can take continuous और interrupted, preferably continuous ले लो. यहाँ पे interlocking भी ले सकते हो अगर hemostasis achieve करना है तो. And that is how you are going to be doing this. But the main thing is, how do you prevent this from happening? How do you prevent these injuries? So there's a guideline in the RCOG latest guidelines. They say that it all depends on your episiotomy. So if this is your vulva, if this is your anus, so they say that whenever you're taking it, first of all, it should be from this point, the posterior fourchette point, and from there, if this is your midline, you have to take it at an angle of 60 degrees. So this angle has to be 60 degrees. Why? Because the head is distending the perineum. And once the head is removed, the baby is delivered, the skin is going to contract. Remember, because the head is coming out, the skin, this is the skin and this is the head, the skin is being stretched out. Once the baby is out, the skin will come back to its normal position, and hence this angle after suturing is going to be at an angle of 45 degree after suturing. Whereas if you take a much lesser incision, if this is your vulva and this is your, if you're going to take midline को बहुत ही 45 डिग्री का इंसिजन अगर लोगे, if this is 45 degree अगर लोगे, then after healing the angle that is going to be remaining is going to be only 22 degree, and that goes very close to your rectum and your anus, which is why this is not recommended, and they say that always take an incision of at an angle of 60 degree to the midline. To support this, this is a study that they have shown that it can be difficult to achieve crowning when the perineum is fully stretched. An episiotomy at 40 degree results in a post-delivery angle of 22 degree, which is too close to the midline to be maximally protective, whereas a 60 degree episiotomy results in an angle of 45 degree, and hence it is the safest thing to do in a mediolateral episiotomy. This is a mediolateral episiotomy. Of course, you do not take a medial episiotomy because it will go and stretch into the rectum and lead to obstetric anal sphincter injury. And that is it about the recent most guideline about taking an episiotomy. A last part of the section is remaining, that is your postpartum hemorrhage. But before we go there, it will take 10-15 more minutes. Has everyone understood everything until now, until this point? Does anyone have any doubts at this point? The session will end now. Does anyone have any doubts up to this point? Only the last point is remaining now, that is postpartum surgeries. So whenever your patient has any postpartum hemorrhage, जब भी postpartum hemorrhage patient को होता है, it can be because of two things. There are four reasons for postpartum hemorrhage. The most important is going to be atony, and the other important cause is going to be trauma, traumatic injury. Of course, there are other two as well: retention of tissue, which will require manual removal of placenta, and the other one being coagulopathy, that is tissue, that is thrombin wala factor, which will require correction with FFP and cryoprecipitate. But these are two classical obstetric things, that is atony and traumatic. So whenever there is atony, the first thing that you're going to do is going to be a balloon tamponade. Of course, you're going to be giving all those medical management, the drugs simultaneously, but a balloon tamponade is done. If you do not have a balloon, you'll be using a Shivkar's balloon pack. Shivkar's balloon pack or a condom pack is where you use a condom, a normal Nirodka condom, and you fill it with normal saline, and then you push it in, you put it in, and you compress it. If this tamponade is not helping, then you take the patient to your operation theater, and then you open the patient and you do a compression test. Compression test is wherein you press the anterior and posterior wall of the uterus, and then you do a per vaginal examination. Your assistant does a per vaginal examination, and they check if the bleeding has continued. If the bleeding has stopped, then you say it is compression test positive, and you can go ahead with a B-Lynch or a Heyman suture. Whereas if the bleeding continues, then you go ahead with a Caesarean section. So compression test is done. If your compression test comes to be positive, you go ahead with a B-Lynch or a Heyman suture. Whereas if it fails, then you go ahead with hysterectomy. So when I talk about A Beeline suture, there are two types. First is a classical Beeline suture and the other one is a Hayman's or modified Beeline suture. Now, classical Beeline suture is done when you have done a cesarean section and there is a cesarean scar. So what you do is 4 centimeters below and 4 centimeters medial. You insert the needle over here and then you bring the needle out from this point on the anterior wall. Then you send it behind. पीछे जाके वापस तुम लोग posterior wall में डालोगे and then ये आके similarly you will reinsert it back here and bring it out over here and then you will tie a knot over here in the center. This is a classical Beeline suture which is done for a cesarean section. Whereas in a patient who has had an atonic postpartum hemorrhage after vaginal delivery, you do not have an incision. Then in that scenario, you will directly send the needle across the anterior posterior wall. So if this is my sagittal view, then in the first scenario, that is in my Beeline suture, this was my uterine incision over here. So what I did was I put the suture from this point, I removed it here, then I put it completely around, then I went behind, I brought it back out, and then I went back in like this, and then I tied it over here. Whereas in this suture, in this is for this B linge. Whereas for Heyman suture, I've directly posted it posteriorly and I've gotten it above and I'll do it tying over here. The knot is going to be tied here. So I'll do it twice, once over here and once on the right side. So right and left side पे दोनों ऐसे करना है. So directly anterior to posterior needle को straight करके I have to insert. So this is the basic difference between Heyman's and classical V-linge suture. The suture material that you use has to be preferably a chromic catgut number 2 and not vicryl. The reason is that after a point of time, your uterus is going to start contracting, but your loops of those suture materials will stay inside. So there have been studies that have shown that chromic catgut, of course, will start hydrolyzing within 2 to 3 days, but your vicryl is going to stay there for 7-8 days. Those 7-8 days can lead to herniation of bowel loops inside that can be fatal. Your bowel loops can herniate inside those loops once the uterus has contracted back. Hence, you prefer to use a chromic catgut number 2, which will hydrolyze immediately after the uterus has contracted. But you can still use vicryl, but it is just a preference ka baat, wherein you will prefer to use a chromic catgut. If this has failed, then the last option that you have happens to be an obstetric hysterectomy, wherein you'll be removing. In obstetric hysterectomy, the commonest method is your classical method, wherein you take your corneal clamps, you cut them, you ligate them, then you go on towards your uterine arteries, you clamp them, you cut them, you ligate them, and finally your uterosacral ligaments, you clamp, cut, and ligate. But if the uterus is bleeding a lot because of atony, then you have your clamp, cut, and drop technique, wherein what you do is you just put in a clamp, you cut it, but you do not ligate it. You drop down to the subsequent level, you drop down to a lower level, that is from corneal to the uterine. You do the same thing there. You clamp it, you cut it, but you do not ligate it. You drop down to further lower level, you clamp, cut, and drop. You remove the uterosacral, you remove the uterus, or that is also called as dropping the uterus outside the operative site. So you remove the uterus and then सब जगह पे जहां पे इंस्ट्रूमेंट्स लगा के रखे हैं, then you start ligating. So basically the uterus is first removed with all the clamps, the metallic clamps in situ, and then you start ligating all the pedicles after the uterus is removed, so that the amount of bleeding that is occurring through the uterus will be reduced. This is the clamp, cut, and drop technique of obstetric hysterectomy. And the last one is retrograde technique, which is not really used, wherein you first do adhesiolysis at the level of cervix, and then uterosacral, then your uterine artery, and then your corneal clamp is what you do. This is done in patients in whom there is bladder advancement and placenta accreta. So that is your retrograde technique of doing an obstetric hysterectomy or a Caesarean hysterectomy. Next, you have your another form of PPH, which can be your acute inversion of uterus. Basically, inversion of uterus. Your inversion of uterus can be of two types. It can be acute or it can be chronic. Chronic is when it has been neglected for a long time, whereas acute is when it has suddenly occurred. Acute is it's an emergency and you need to do something that is life-saving, whereas chronic is something that you can electively post and do something about it later. So for acute, the first thing that you can do is manual reposition, wherein you will with your hand reposit the uterus inside and then start the patient on uterotonics, because the uterus will start contracting. If that doesn't work, then you have your O'Sullivan, which is your warm saline and hydrostatic method. Warm saline of 40 degrees is inserted inside a balloon, and your hydrostatic method is this one. So you basically use warm saline ka pack to push the uterus upwards. You also have Shirodkar's packing method, wherein you pack the uterus with roller gauze pack. So basically you push it with a roller gauze and you push it upwards. And lastly, if none of this works, then you open the patient and you do the Huntington procedure. In Huntington procedure, this is going to be how it looks inside the abdomen. You see that this is your ovary, these are your fallopian tubes, this is your bladder, and this is your rectum. So what you will do is you will take two Allis or Cocker's clamps. You're going to attach it over here, one and the other one over here, and then you're going to pull the uterus upwards. This is called as the Huntington's procedure, wherein applying at the round ligaments are going to be at the point of attachment of the fallopian tube to the uterus. Udhar dalke, you will be pulling it upwards. If there is any obstruction, if there is any ring, there is a constriction ring that has formed, I can even take an incision on that constriction ring called as the Holtein's incision. If there is any ring that is obstructing my pulling up of the uterus. Once it is pulled up, I will start the patient on uterotonics and I will hold the uterus in its location, and then I will wait for the uterus to gain its tone. The uterosacral will also regain their tone, and then the uterus will not fall out again. This is the Huntington's procedure. For chronic inversion, I have to cut the ring. The reason it is chronically inverted and it is not going out is because there is a fibrotic ring. So that fibrotic ring can be cut vaginally through an anterior incision called as a Spinelli's incision. I've taken a separate class on this, or a posterior incision called as a Kushner's incision. Basically, there's a ring that is formed. That ring is either cut anteriorly or posteriorly, and once it is cut, the uterus can be reposited back from the vagina. If the same thing is done from the abdomen, it is done by the Holtein's incision, which I just spoke about. So these are the various forms of methods for acute inversion of the uterus. Lastly, about traumatic PPH. So whenever there is traumatic postpartum hemorrhage, I have to stop the blood supply that is coming to those traumatic parts, apart from, of course, repairing them. So to do that, the first thing that I can do is uterine artery ligation, or what I call as the O'Leary stitch. So I have to know that if this is my uterus, I have my anterior branch of internal iliac artery coming over here. It goes down to form the descending cervical artery, and it comes upwards from the uterine artery. So this uterine artery at the level of internal os on both the sides has to be ligated. This ligation will include, now by the way, you have your broad ligament over here on both the sides. So what you do is, broad ligament is just a leaf. So what you do is, the stitch that you take has to include your lateral wall of myometrium and the broad ligament, and you have to take the uterine artery inside it. Because if you take it just, अगर तुमने सिर्फ इसको इतना सा लिया, then this will completely go away. The injury, basically the uterine artery is going to be sheared off, and there will be a torrential amount of bleeding, which is why always remember that whenever you do uterine artery ligation, it has to be by taking the lateral wall of the uterus into consideration. It has to be taken into it so that यहाँ पे आके वो completely compress होके ligate हो जाए. This is called as the O'Leary stitch, which is bilateral uterine artery ligation done with the help or between the broad ligament and the lateral wall of the uterus. If this doesn't help, then I go back, I realize that there are more bleeders, there are more uterine artery के collateral vessels that are there inside this. ये जो uterine artery के collateral vessels है, उनको भी मुझे बंद करना है. So for that, I'll be doing internal iliac artery ligation. Internal iliac artery ligation, I have to remember that is a branch of aorta. आयोटा से नीचे आता है कॉमन इलियक. कॉमन इलियक से आते हैं मेरे दो ब्रांचेस, इंटरनल एंड एक्सटर्नल. External forms the femoral artery, so I have to remember that I do not take external iliac, I have to leave it alone. The internal branch has anterior and posterior branches. The distance between them is around 4 centimeters. So once I locate the internal iliac branch, I will go ahead 4 centimeters and then I will ligate the anterior branch, because if I ligate it near the internal iliac origin, then even the posterior branch is going to be lost, which is going to supply the gluteal region. That will lead to gluteal insensitivity. So gluteal region को मुझे spare करना है, which is why 4 centimeters away from the origin of the anterior branch is where I will ligate this. And this anterior branch is the one that provides the uterine artery, descending cervical, vesical branch, and perineal branches. All of them are going to be provided by the anterior branch of internal iliac. So you have to ligate the anterior branch of internal iliac, which is around 4 centimeters downstream from the origin of internal iliac. This is called as stepwise devascularization. Stepwise devascularization is basically first I tried the uterine artery, it didn't work. Then I went ahead and then I clamped the internal iliac, the anterior branch, it didn't work. Then I went ahead and ligated the entire internal iliac, not just the anterior branch. So this is stepwise devascularization of the pelvis. How does this help? Once I do this stepwise devascularization, it reduces the blood pressure inside the pelvis by 45%. 45% का drop आता है, and the pulse pressure is reduced by 80%. So what this does is basically the trip hammer effect of the blood vessels which throws off. अगर ये मेरा blood vessel है और यहाँ पे कोई clot बन रहा है, उसको वो उड़ा देता है, the trip hammer effect. This is called as the trip hammer. Basically the clots are just flung away because of the pressure. By ligating them, this pressure of the pelvis reduces, and these pressures are reduced to venous levels. तो वीनस सर्कुलेशन जितने उसके अंदर ब्लड प्रेशर के लेवल्स होंगे, एंड वीनस प्रेशर कैन बी amenable to compression. So whenever I will compress it with a mop or a gauze piece for the period of clotting time, bleeding time jitna hai, and once those clots are formed, they will not be removed by the blood pressure because it has been reduced by the ligation. So whenever you do bilateral, even if you do unilateral of just the right side, because left side में sigmoid colonnade is enough, but if you do it for both the sides, the trip hammer effect is removed and your pelvic vasculature is going to be amenable to compression, and eventually your hemostasis is going to be achieved. This is the logic behind doing internal iliac artery ligation. It converts your arterial pressure system to venous pressure system inside the entire pelvis. This is called as stepwise devascularization. And lastly, a very simple topic, that is tubal ligation. Very simple, I don't need to talk much about it. This is the Pomeroy's technique which we regularly use, modified Pomeroy, wherein we make a loop and we cut it off. The Irving's method is wherein I separate them completely and I tie it off. And the fimbriectomy, the last method wherein I just remove the fimbria. Very simple. The best way of doing tubal ligation is bipolar cauterization at 3 different locations. And with that, I finished tonight's session. Does anyone have any doubt? Did everyone understand the session completely? Does anyone have any doubt? Has everyone understood this session? If there are any doubts, do let me know. Tubal ligation is not a topic you have been reading it since your undergraduation, so I wouldn't be discussing too much about it. Did everyone understand everything, or does anyone have any doubts? Let me know right now. Please repeat anal sphincter suturing technique. If I'm going to repeat it, it is a lot. Yes, end-to-end technique. See, ES may you can either approximate end-to-end or you can overlap them. So the preferred method is end-to-end, wherein you attach them this way. So when you attach them this way, now if this is anterior and this is posterior, the first stitch that you will be taking is going to be posteriorly. Then you take a superior stitch, then you take an anterior stitch, and then you take an inferior stitch. So basically at 4 locations, I have locked it and have completely sutured off the external anal sphincter. That is how I'll be suturing it. You can also do the overlapping technique, but that increases your anal opening pressure, and that is going to be difficult for the patient to defecate. How to approach internal iliac artery? How to approach internal iliac artery? You have to ligate and open your round ligament. Once you open your round ligament, your broad ligament leaves are going to be opened up. Then with your artery, blunt artery, you will keep on opening and you will go posteriorly. Once you go posteriorly, you will see the ureter. Medial to that, you will see your internal iliac artery. So trace it till the origin. Once you trace it till the origin, 4 centimeters distal to that will be your anterior branch. The posterior branch would have left already. That is where you ligate. You use a mixter. A mixter is an instrument which is at right angle, and then you pick it up and then you ligate it. Any other doubts? Does anyone have? How to approach the internal iliac? I hope you all have understood everything. Does anyone have any doubt whatsoever in this session? It was a long session. I've discussed more than 50, 53, sorry, 30, 33 procedures. Does anyone have any doubt? Can we combine both methods, B-Lynch and bilateral uterine artery? I don't believe bilateral uterine artery and B-Lynch have to be combined. I'll tell you the reason. you can do it, and in fact we do it. But I also feel that whenever you ligate the uterine arteries, the blood supply to your uterine musculature, which is anyway low, which is why the uterus is not contracting, will go down even further. That will lead to even more difficulty in the uterus contracting. So though a lot of people do it, uterine artery ligation कर सकते हैं, it is a way, but I feel that atony उससे थोड़ा और prolong हो सकता है. But yes, a lot of people do it, even I would personally do it. But that is the thinking behind it, that if you ligate the uterine arteries, then the blood supply to the myometrium, which is required for the involution, will go down even further. So the atonic episode can prolong. So I hope everyone understood all the topics, and I hope I can end this session. I hope you liked it. I would love having your feedback. This was the longest session that I've ever taken, 2.5 hours. I would love listening to you and your comments on this session. Please let me know in the feedback in the live chat if you all have liked this session, and if you would want me to take more such sessions. If you all have any doubts, do message me. I'll solve them for you. This has been the longest session and the most tasking session for me personally. I just come back from work half an hour before. So thank you so much, and good night, everyone. Keep watching Conceptual OBG. We have our new MCQ books that are coming up. Our MCQ have been started, they have been uploaded on the app, and they'll be launched by this month end. The books shall come out by next month end. We have over 10,000 MCQs for all your entrances. So do check them out. So thank you so much, everyone, and good night. Thank you, Gaurav.
Thank you, sir. Good night.